The order came before the helicopter did. Fire her. Tonight. I want her badge on my desk before morning rounds. Dr. Victor Harlan's voice cut through the emergency department like a scalpel clean, deliberate, designed to end things without discussion. 38 nurses, techs, and residents heard it. The department absorbed the words and went still in the way that institutions go still when authority speaks without expecting a response. Nobody moved. Nobody breathed loud enough to be noticed. Emily Shen stood at the trauma bay entrance, gloves still on, a faint smear of blood across her left forearm from a patient she had spent the last 40 minutes keeping alive, and she didn't flinch. She had heard worse. She had survived worse. In places where the air tasted like cordite and diesel smoke, and the only light came from a headlamp held between someone's teeth, where the ground shook in a way that had nothing to do with weather and everything to do with what human beings do to each other when diplomacy runs out. Emily Shen had knelt in the dirt beside men who had about 4 minutes left in them and made decisions that no nursing protocol on Earth had ever anticipated. She knew what worse looked like. She knew exactly what it smelled like. Victor Harlan's voice was not worse, but it was coming, and she knew it. Then the windows rattled. Not thunder, not an equipment problem. The specific low-frequency concussion of military rotor blades at close range of sound that lives in a different register than civilian aircraft. Heavier and more deliberate, the kind of sound that doesn't so much arrive as it announces itself from a distance and then closes the gap. The fluorescent lights in the ER hummed in sympathy with the vibration. A supply cart near the nurse's station rattled against its brake. And then a Black Hawk helicopter dropped below the cloud line above Ridgemont Trauma Center in Salt Lake City, Utah, its belly lights cutting white arcs across the rooftop pad. And 60 seconds later, a man in a general's uniform walked through the emergency department's main entrance and asked for Emily Shen by name. Before we go any further, if this is your first time here, hit that subscribe button right now. This channel runs stories like this one every single week. Real tension, real stakes. People pushed to the absolute edge of what they can handle. Drop a like on this video and leave a comment telling me what city or country you're watching from. I want to see exactly how far this story travels across the world before it's done. Now, let's go back to the beginning, where all of this actually started. Emily Shen arrived at Ridgemont Trauma Center on a Tuesday morning in early November and was assigned to Bay 4 before she had finished her first cup of coffee. Every emergency department had a Bay 4. The number didn't matter. It was always the same bay, regardless of what it was called. The monitors were a generation behind the rest of the floor. The overhead light flickered on a 12-minute cycle with the reliability of a failing metronome. The supply cart was missing its crash kit drawer handle, replaced years ago by a strip of blue surgical tape on which someone had written in thick black marker, "Pull hard, curse freely." Bay 4 was where hospitals put nurses. They hadn't decided what to do with yet transfer-ins without enough institutional history to earn a better assignment. Nurses who came with paperwork that said excellent in every evaluation box, but carried something in their bearing that made the senior staff vaguely uncomfortable in ways they couldn't articulate. Emily carried that something. She was 34 years old, with dark hair pulled back tight enough that it never drifted, precise in her movements, in the way that people are precise when they have spent years operating in environments where imprecision had consequences that extended far beyond paperwork. She was not cold. The patients figured that out within the first 5 minutes of being in her care, but she was contained, and to someone meeting her for the first time across a busy emergency department, that containment looked like a wall. Dr. Victor Harlan had looked at it and decided it was arrogance. He was chief of emergency medicine at Ridgemont, 49 years old, 2 decades into a career built on genuine clinical skill that had slowly, over time, become insulated from any serious challenge. He was not a bad doctor. That was the part that made everything complicated. He was sharp and decisive, and had trained attending physicians who now ran departments at hospitals across the region. His outcomes were good. His instincts were usually right. But 20 years in a position where being right had never once required him to reconsider his process had done something to the architecture of his thinking that no amount of continuing medical education could address. He had reviewed Emily's transfer file. He saw the nursing credentials, the trauma certification, the critical care hours, solid, nothing spectacular. He saw the gap in her employment history, 3 years, listed as federal service, non-clinical. He had read that as filler language. Some administrative role, maybe. A desk somewhere. He assigned her to Bay 4 and moved on. That was his first mistake. It would not be his last. Emily didn't complain about Bay 4. She arrived 20 minutes before her shift began, sourced a replacement drawer handle from the equipment room down the hall, installed it herself, recalibrated all 3 monitor leads, and submitted to a detailed maintenance request for the overhead light that specified the flicker interval, the probable cause, a failing ballast rather than a bulb issue, and the patient safety implications of a compromised lighting environment in a trauma bay. By the time her first patient rolled in, Bay 4 was a functional workspace. Her charge nurse that evening was Donna Reyes, 42 years old, 15 years in trauma nursing, the kind of person who had survived long enough in emergency medicine to stop being surprised by anything and start being surprised by people. She watched Emily move through the first 2 hours of the shift and said nothing. But she started appearing near Bay 4 more frequently than her other responsibilities required. The ER was busy. November in Salt Lake City meant black ice, which meant collisions, which meant the department ran at near capacity from 8 p. onward with the grim efficiency of a machine that had been designed for exactly this kind of sustained pressure. Emily worked her patients with a rhythm that looked almost mechanical until you watched closely enough to recognize it as something entirely economy, not automation. Every movement had a destination. She talked to her patients in a low, steady register that didn't perform calm so much as actually produce it in the room around her. She documented with the same precision she applied to everything else. Twice during those first 2 hours, she flagged medication discrepancies on adjacent charts, not her patients. Patients she had simply passed in the course of moving through the department and reported them to the appropriate residents without drama or commentary. Dr. Harlan saw this. He didn't say anything about it. He filed it in a category he wasn't fully aware he maintained, things that don't fit where I've put her. He filed it and moved on. At 11:40 p.m., Marcus Webb arrived by ambulance. He was 26 years old, the product of a rear-end collision on I-15 at highway speed airbag deployment, mild laceration on his chin from the steering wheel, GCS of 15, alert and answering questions clearly. The paramedics had run a solid field assessment. His vitals on arrival were acceptable in the way that vitals in the early stages of internal hemorrhage are often acceptable. Blood pressure 108/72, heart rate 101. Oxygen saturation at 97% on room air. He was talking. He was coherent. He was rating his pain at a 6 and telling the paramedic he thought he was probably fine. He came to Bay 4. Emily began her assessment, while the paramedics were still completing the transfer. She listened to his chest breath sounds equal bilaterally, no abnormality. She moved her hands across his abdomen, systematic, watching his face as much as feeling for findings. His abdomen was soft, no obvious rigidity, no guarding, until she pressed the left upper quadrant. There, a small, involuntary tightening. A flinch controlled fast enough that a less attentive examiner would have attributed it to general tenderness and moved on. She pressed again. Same response. "Tell me about what you feel right there," she said. "When I press, it's..." Marcus paused, organizing the sensation. A dull ache. Kind of spreading out when you do that. "Has it changed since the crash? Better, worse, the same?" He thought about it. Maybe a little worse. I figured it was bruising. Emily looked at his hands. She had a habit of looking at hands. His nail beds were pale in a way that was subtle enough to be dismissed as baseline variation, and his capillary refill came back at 2.5 seconds. Not alarming, not individually alarming, but there was a pattern assembling itself from a series of individually non-alarming data points, and the pattern had a shape she recognized. She flagged the chart for Dr. Harlan and stayed with Marcus until the attending arrived. Harlan came in 3.5 minutes later, reviewed the vitals board, performed a quick physical assessment with the confident speed of someone who has run this particular sequence thousands of times. He asked Marcus 2 questions and listened to the answers and made a decision. CT of chest, abdomen, and pelvis with contrast. Standard protocol. Emily stepped closer. I'd like to add a fast exam alongside the CT. His left upper quadrant response and the capillary refill trend. CT with contrast is the diagnostic standard for blunt abdominal trauma. Harlan didn't look at her. He was already typing the order. I'm aware of fast protocol, Nurse Shen. I understand that. I'm not suggesting replacing the CT. I'm suggesting we run both concurrently. The scanner is backed up, and if the CT order is placed. He looked at her then briefly. The expression of a man exercising patience he hasn't been asked to exercise in quite some time. Unnecessary duplication of diagnostics creates confusion in the workup. Let the CT do its job. He moved to the next bay. Emily stood at Marcus Webb's bedside and said nothing for a moment. Then she pulled the blanket up to his chest, checked his IV line, and checked the clock. 11:47 p.m. The CT scanner had a 40-minute backup. 40 minutes was not unusual. Ridgemont ran 2 operational scanners for a Level 2 trauma center, serving the broader Salt Lake metro area, and on a busy November night with black ice on the roads, 40 minutes was a Tuesday. Emily documented the scanner delay in Marcus's chart, time-stamped, and adjusted her vital sign check frequency to every 8 minutes instead of the standard 15. At 12:22, his blood pressure read 104/68. At 12:30, 101/65. Small drops, the kind of drops that could be positional artifact, could be anxiety response, could be the natural variability of a young body managing moderate pain, could be half a dozen things that were not dangerous and would resolve on their own without intervention. Or they could be something else entirely. Emily went to the storage alcove and retrieved the portable ultrasound unit. She brought it to Bay 4, applied gel to the probe, and positioned it over Marcus's right flank, Morrison's pouch, the anatomical space between the liver and the right kidney. One of the first places fluid collects in abdominal hemorrhage. She looked at the screen. The image took a moment to resolve through the artifact from his subcutaneous tissue. Then it was clear, a thin crescent of anechoic fluid. Free fluid, blood most likely, not a massive volume. But there. Emily photographed the image with the department's clinical camera, uploaded it directly to Marcus's chart with a time-stamped note, and walked to the physician workstation, where Dr. Harlan was completing documentation on a separate case. She placed the uploaded image on the screen in front of him and said, "Free fluid in Morrison's pouch. He needs a surgery consult now." Harlan looked at the image. He looked at it for a full 4 seconds longer than a dismissal would have required. Then he said, "That's artifact. The portable unit in Bay 4 has a degraded transducer head. The CT will give us the definitive picture. His pressure has dropped 9 points in 22 minutes. Within acceptable variance for his presentation." Dr. Harlan, 9 points in 22 minutes on a trauma patient with LUQ tenderness and suboptimal capillary refill is not variance. I'm comfortable with. Then I suggest you adjust your comfort level. He turned back to his documentation. The CT order stands. Return to your patient and monitor his vitals per protocol. I am monitoring his vitals. That's why I'm here. He set his pen down. He turned to face her fully, and his voice dropped into a register that was quieter and therefore considerably more pointed than it had been. Nurse Shen, you have been on staff in this department for 72 hours. You do not countermand attending physician orders on the basis of a portable ultrasound in a compromised bay environment. That's not how this works here. Return to your patient. 2 seconds of silence. Emily turned and walked back to Bay 4. She checked the monitor the moment she arrived. 100/62. She pulled the stool close to Marcus's bedside and sat down. He was watching her. Eyes had gone slightly glassy. Not altered, not confused, but tired in a way that was moving faster than a young man's normal fatigue should move. Is something wrong? He asked. She looked at him directly. I'm watching your numbers carefully. That doesn't sound like nothing's wrong. It means I'm paying attention, she said. That's what I'm supposed to do. He was quiet for a moment. That doctor and you don't agree about something. We have a difference of clinical opinion. Marcus looked at the ceiling. He's the doctor. He is. But I think you're in good hands, Emily said, and I am going to be standing right here. She meant it both ways. Donna Reyes found her 3 minutes later. Emily gave her the full report without editorializing, the LUQ, finding on palpation, the fast image and what it showed, the vital sign trend, the physician's response. Donna listened without interrupting. Her face stayed professionally neutral through most of it, and only when Emily described the 9-point pressure drop in 22 minutes did something move behind Donna's eyes, a small, controlled acknowledgement. Everything documented, time-stamped entries, image uploaded. All of it. Donna looked across the department toward the physician workstation. I'll go talk to him. He won't hear it. Probably not. But I'll document that I tried. She met Emily's eyes. You see the systolic break, 100. You come find me immediately. Not in 2 minutes. Immediately. Emily nodded. Donna crossed the department. The conversation with Harlan lasted 40 seconds. Emily watched it from the bay entrance. Donna speaking with the measured precision of someone who has learned to make institutional arguments in the shortest possible form. Harlan listening with the patience of a man who has already made up his mind. Harlan responding in 3 words that made Donna's shoulders lower by a fraction before she turned and walked back. She passed Emily and said quietly, without stopping, "He's calling CT to bump the scan up." 18 minutes. Emily looked at the monitor. 97/60. She did not say anything. She pulled on a fresh pair of gloves. At 12:49 a.m., Emily placed 2 large-bore peripheral IV lines in Marcus Webb's arms, a 16-gauge in the right antecubital and an 18-gauge in the left forearm, and hung a bag of normal saline running wide open. She had not been ordered to do either of these things. She had done them because the math had run to its conclusion, and the conclusion pointed in one direction. She was adjusting the IV tubing when Dr. Harlan walked into Bay 4. Behind him were 2 residents, both of them young, both of them doing the specific kind of watching that junior physicians do when they're not sure which senior person in the room to learn from. Behind them, at the bay entrance, was a hospital security officer. Harlan looked at the IV lines. His jaw tightened the way a closed door tightens when someone on the other side is pushing against it. Nurse Shen. Step away from the patient. His pressure is 97/60 and trending. I can read the monitor. His voice had dropped into something flat and very precise. Step away from the patient now. I have large bore access established and fluids running. If he decompensates in the next. You placed IV lines without a physician order. He said it the way a judge reads a finding factual, conclusive, designed to be heard by everyone in the room. That is a protocol violation. You are removed from this case effective immediately. He looked at the security officer. Please escort Nurse Shen to the hallway. The security officer stepped into the bay. Emily looked at Marcus. His eyes were half open. His skin had taken on a waxy quality that it hadn't had 40 minutes ago. subtle, the kind of thing you only caught if you'd been watching the whole progression. She looked at the two residents. Neither of them met her eyes. She looked at Dr. Victor Harlan, and she understood in that moment, with complete clarity, exactly what kind of wall she was standing in front of. She took one step back. Then she did the thing she hadn't planned to do. She reached over and picked up the ultrasound probe. She had kept the machine running at the bedside throughout the shift, and she pressed it to Marcus Webb's abdomen one final time. She angled the screen so that both residents could see it. The image was unmistakable. What had been a thin crescent of free fluid 40 minutes ago had expanded into a visible pool. The hemorrhage was accelerating. She held the screen in place for 4 seconds. "The bleeding has increased significantly in the last 40 minutes, she said, addressing the residents, not Harlan. "He does not have 18 minutes. One of the residents, the taller one, a young woman who had been watching the proceedings with the expression of someone doing rapid internal calculations, looked at the screen, looked at the monitor, and looked at Dr. Harlan. Harlan stepped directly in front of the ultrasound screen, blocking it. "Remove her," he said to the security officer. Emily set the probe down carefully on the machine's armrest. She pulled off her gloves. She walked out of Bay 4 without looking back, and the security officer followed her into the hallway. And the door behind her swung shut, and she stood in the corridor of the emergency department with 12 feet between her and the patient she had spent the last 72 minutes trying to keep alive. She did not move. She stood in the hallway, and she breathed, and she counted the seconds. She had reached 11 when the blood pressure monitor alarmed. She heard it from the hallway, the sharp triple tone of a monitor hitting its lower threshold. Then she heard a second alarm join it. Then she heard the quality of Dr. Harlan's voice change from behind the bay door. Not the words, just the register, the specific compression of authority into something faster and more reactive, the sound of a man shifting from administrative mode into clinical emergency. She heard one of the residents call out a number. She heard the word surgery. Donna appeared beside her. She had come from the nursing station without being called, because 15 years of working in trauma had given her the ability to read a department's atmosphere the way some people read weather by feel before the instruments confirmed it. "Surgical resident is already on his way down," Donna said quietly. Martinez called him, without authorization. Martinez, the taller resident, the one who had looked at the ultrasound screen. Emily nodded. The bay doors opened, and the surgical resident, a third-year named Garza, who had the compact intensity of someone who slept in 4-hour increments and had made his peace with it, came through at a near run. He stopped at the bay entrance, looked at the monitor, looked at the ultrasound image still displayed on the screen at the bedside, and was on the phone in under 10 seconds. Emily stood in the hallway and listened to the department reorganize itself around the crisis. The IV lines she had placed were now the IV lines the surgical team was using to push fluids into Marcus Webb while they moved him toward the elevator. The access points she had established without an order. The access points she had established without an order were the access points that currently represented systems between Marcus Webb's circulatory system having a viable pathway and not having one. The bay door opened. The gurney came out. Marcus's face was pale, and his eyes were only partially open, and his blood pressure was reading 88/54 on the transport monitor, and the surgical resident was walking alongside the gurney with his hand on Marcus's arm, talking to him in a low, steady voice, and the OR team met them at the elevator. Emily watched the elevator doors close. She stood in the hallway for a moment after they closed, and the department resumed its ambient noise around her. And she was alone in the particular way that people are alone in the aftermath of a crisis they prevented. Partially, but not completely, where the outcome is still unknown, and there's nothing left to do but wait and document and hold the shape of what happened without letting it collapse into something shapeless. She walked to an open workstation. She sat down. She started typing. At 1:14 a.m., Dr. Victor Harlan came to the nursing station. He stood at the edge of it for a moment without speaking, and his posture had the specific quality of a man who has just experienced something that doesn't fit the model he's been operating from and hasn't yet found a way to reclassify it. His jaw was set. His eyes were moving across the department with the slight unfocused quality of someone running an internal conversation. "Where is Nurse Shen?" he asked Donna, documenting. He was quiet for 3 seconds. "She violated protocol tonight," he said. "The unauthorized ultrasound, the IV placement without an order, the direct disregard of a physician directive to step away from the patient." He paused as if organizing these into a formal structure. "I want her written up. Suspension pending formal investigation. Possible termination recommendation." Donna kept her face exactly as composed as she always kept it. "I'll need that in writing before I can process it," she said. "You'll have it." He turned and walked back toward his office. Donna waited until the office door was closed. Then she walked to the back workstation where Emily was still typing and said, at a volume calibrated precisely for one person, "He's pushing for suspension and possibly termination. He's putting it in writing tonight." Emily continued typing for another 4 seconds. Then she stopped. "Okay," she said. "That's your response? Okay. What would you like me to say?" Donna pulled a chair close and sat down. She looked at Emily's face. Whatever she found there, that containment, that particular quality of stillness, she studied it for a moment, the way you study something you've seen before, but understood. "You're not scared," Donna said. "I'm concerned about Marcus Webb's surgical outcome." "That's not what I asked." Emily looked at her hands on the keyboard. "I've been in situations that were harder than this," she said. "Significantly harder." "The 3-year gap in your file," Donna said. It wasn't quite a question. Emily didn't answer. "Federal service, non-clinical." Donna tilted her head. "I've been working trauma long enough to know what non-clinical usually means in a file like yours." "Then you probably don't need me to explain it." Donna sat back in her chair and was quiet for a moment. "He's going to try to fire you," she said. "Tonight, with paperwork, before you have a chance to build a response." "I know. Do you want union representation?" "Not yet." Donna. Emily turned to face her. "I need a little more time. I need you to trust that I understand what's happening and that I'm not handling it carelessly." She held the older woman's gaze. "Can you do that?" Donna looked at her for a long, assessing moment. "For somebody who's been here 72 hours, she said finally, "you are the most annoyingly calm person I've ever worked with. I've been told that. Is it a compliment where you come from?" Emily turned back to the keyboard. "Usually," she said. At 1:57 a.m., Dr. Victor Harlan returned to the floor with Patricia Voss, the chief nursing officer, who had been called from home and carried in her posture the displeasure of someone who has been interrupted from sleep for institutional reasons that could have waited until morning, but apparently couldn't. He had the suspension paperwork. It was formal, typed, and signed. Emily was brought to the nursing station and informed of the action. She read the document. Harlan stood on the opposite side of the counter and waited with the patience of a man who expected the situation to proceed in a single, uncomplicated direction. "You'll need to acknowledge receipt and surrender your badge to security," he said. "The formal investigation will begin at the start of business tomorrow." Patricia Voss stood slightly behind and to the left, in the administrative position of someone officially present but not yet fully committed to a side. Emily picked up a pen. She was positioning it over the acknowledgement line when the building shook. Not structurally, not seismically, rotor wash. The deep mechanical resonance of a military helicopter at close descent, a sound that operates below the threshold of normal hearing and is felt more than heard, a vibration that moves through floors and walls and the soles of your feet. Every light fixture in the ER hummed. The supply cart near the station rocked against its brake. 2 nurses near the central desk looked up at the ceiling simultaneously. The way animals orient toward a sound before they've consciously processed what it means. The rotor noise built until it was impossible to speak over, and then it stopped. The department went quiet. The entrance doors opened. They came in 4 across 2 in Army combat uniform, 2 in dress greens, and then behind them, moving with the particular unhurried gravity of a man for whom rooms rearranged themselves as a matter of course, came a brigadier general in full dress uniform. Single star, rows of service ribbons, a face that had spent 30 years in environments that left their mark on a person and had left all of those marks on his. He stopped inside the entrance. His eyes moved across the emergency department, not cataloging equipment, not assessing the layout, but reading the people, the way people who have spent careers in high-stakes environments read rooms. He was looking for one specific person, and he found her in under 5 seconds. He walked directly toward the nursing station. "Doctor!" Harlan stepped forward. "General, this is a restricted clinical area. You cannot simply..." The general walked past him as if he hadn't spoken. He stopped 2 feet from Emily Shen. He looked at the suspension paperwork on the counter in front of her. He looked at her face. His expression was not soft, and it was not dramatic. It was the expression of a man who has arrived somewhere and found exactly what he expected to find, which made him neither relieved nor surprised, only confirmed. He raised his right hand. He rendered a full formal military salute. In the center of Ridgemont's emergency department, at 1:59 in the morning, with Patricia Voss's hand frozen halfway to her notepad and Victor Harlan standing with his mouth partially open, and 24 of our staff watching from every angle the room permitted, Brigadier General Daniel Marsh saluted Emily Shen. The department was so quiet that you could hear fluorescent lights. Emily looked at him. For the first time that entire night through, the dismissals and the orders and the security escort and the suspension paperwork, something moved through the stillness in her face. Not triumph, not relief. Something quieter and older than either. "Sir," she said. Marsh lowered his salute. "I've been trying to reach you for 6 hours. I've been on shift. I know that now." His eyes dropped to the paperwork on the counter, then came back up. "I can see what kind of shift it's been." He turned. He looked at Victor Harlan with the specific quality of attention that very powerful people reserve for moments when they need someone to understand something without the option of misunderstanding it. "Who are you?" Marsh asked. Harlan straightened. "Dr. Victor Harlan, Chief of Emergency Medicine at this facility. And I need to understand the authority under which a military minus. The nurse you ordered removed from her patient tonight," Marsh said, "served 31 months as a Special Operations Combat Medic attached to the 75th Ranger Regiment. She treated penetrating trauma and hemorrhagic shock in active combat conditions, without imaging equipment, without surgical backup, without the option of waiting for a better answer." He paused. "She has more documented trauma hours than every physician in this department combined. And based on what I was briefed on the drive-in, she identified and flagged a hemorrhagic injury tonight that your protocols were running out of time to catch." The silence in the department had weight. Harlan's face had gone through several transitions in the past 30 seconds. It had not yet settled on a final one. Marsh turned back to Emily. "The patient," she said. "Webb, what's his status?" One of the uniformed personnel had a device in hand. "Surgery is ongoing. Stable at last update." Emily nodded once. She reached across the counter and picked up the suspension paperwork. She looked at it for a moment, really looked at it, not performing the moment, but simply acknowledging what it represented, what the night had been, what it had cost in the specific currency of being the person in the room who is right before everyone else is ready to believe it. Then she held it out to Victor Harlan. He didn't take it. He was looking at her, and she recognized the expression, not because she had seen it on his face before, but because she had seen it on enough faces over enough years to know what it looked like when a person is doing the very particular work of revising something they have held as fixed. It was not a comfortable expression. It was not supposed to be. Nobody in the department spoke. And 3 floors above them, in an operating room, and that smelled like antiseptic and controlled urgency, the surgical team working on Marcus Webb was using the IV access Emily had placed without authorization, working in the time window her unauthorized ultrasound had created, racing to stop the bleeding that her dismissed clinical instincts had been the first to identify. And whether that was going to be enough was still, at 1:59 in the morning, a question that only the next hour would answer. He didn't take it. The paperwork stayed in Emily's outstretched hand for 4 full seconds before she set it back on the counter without ceremony, without making a production of it, without doing anything that could be read as theater. She simply placed it down and stepped back, and the gesture was more devastating than anything she could have said because it communicated without ambiguity that she had already moved past this moment, even while everyone else in the department was still processing it. General Marsh turned to the 2 uniformed personnel behind him and said something in a voice too low to carry across the station. One of them nodded and moved toward the corner of the department with a phone, pressed to his ear. The other positioned himself near the entrance with the relaxed watchfulness of someone doing a job he had done many times in many different rooms. Patricia Voss, the chief nursing officer, was the first administrator to find her footing. "General Marsh," she said, stepping forward with her notepad in hand and the careful precision of someone who has spent a career navigating situations where multiple institutional authorities are in the same room. "I want to make sure I understand what's happening here." "You're here in an official capacity?" "I'm here because one of my people needed me here," Marsh said. He said it simply, the way people state facts. They don't feel the need to defend. "Your people," Voss repeated. "Sergeant First Class Emily Shen. Retired." He glanced at Emily, something brief and private in it. "She went quiet about 2 years ago when she transitioned out. Took some time. We respected that." He paused. "When I got word of what was happening here tonight, I stopped respecting it." Voss made a note, or pretended to. Emily could see that her pen wasn't moving. Harlan had not spoken since Marsh's initial statement. He was standing slightly apart from the group now, not retreating exactly, but creating distance in the incremental way that people create distance when the ground has shifted beneath them, and they haven't yet worked out where the new solid ground is. His face, psychologically, professionally, his face had completed its transition through the various expressions it had been attempting and settled on something that wasn't quite stonewalled and wasn't quite chastened, something in between, something that looked like a man running calculations he wasn't sure he had all the inputs for. Emily watched him from the corner of her vision. She had worked alongside enough people like Harlan to know that this moment, the public moment, the exposure, the arrival of an authority that operated outside his institutional structure, was not the moment that would actually change anything. These moments could wound pride without touching the underlying architecture. She had seen men absorb moments like this and then spend the following weeks quietly, systematically, reinstating everything that had been challenged, using the tools available to people who still held institutional power after the cameras, metaphorical or otherwise, had stopped running. The general standing in this ER was significant. The system that had produced Dr. Victor Harlan and reinforced him for 20 years was significantly larger than one general. She knew that. She had learned it in contexts that made this one look simple. But the next hour had its own requirements, and she turned her attention back to them. "What's the OR's contact number for surgical updates?" she asked Donna. Donna blinked, recalibrating from witness mode to operational mode with the speeds of someone who had been doing this job long enough to switch between the two in under a second. She recited the extension. Emily pulled out her phone, noted it, and moved to a side wall where the lighting was steadier and the ambient noise was manageable. Marsh watched her make the call. He said nothing. He understood operational focus when he saw it. The surgical resident who answered the OR phone was not Garza, was scrubbed in, but a second-year named Holloway, who had been positioned at the circulators and had the crisp, information-dense communication style of someone who had been taught to give surgical updates to anxious people in the minimum possible words. Webb, Marcus, he's stable on the table. Dr. Okafor is managing the bleed. Liver laceration, grade 3, and a small tear in the mesenteric. Holloway paused, as if checking something. It's contained. They're about 90 minutes from close, maybe less if the field stays clean. His pressure when he came in, 82/48. They had him back to 96/60 within about 8 minutes of getting product running. Emily did the math on that in her head. The distance between 82/48 and viable. The distance between where Marcus had been when the monitor alarmed and where he was now. The margin was not comfortable. It was the kind of margin that sometimes held and sometimes didn't, and the difference between those two outcomes often came down to how much time had been lost before the right decision was made. "Thank you," she said, and ended the call. She stood at the wall for a moment with the phone in her hand and let herself feel the particular physical sensation of a situation that is not yet resolved, but has moved far enough from the edge that breathing is possible again. It wasn't relief. Not yet. Relief required a conclusion. This was something smaller, the momentary loosening of a fist that had been clenched for 2 hours. She put the phone away and walked back to the nursing station. Marsh was talking to Patricia Voss in a low, measured voice. He was not aggressive. He didn't need to be. There was a quality to his communication that Emily recognized from the field, the absolute absence of performative urgency, because the confidence behind it didn't require performance. He was explaining something. Voss was listening with the full attention of someone who has just understood that the situation she walked into is considerably more complicated than it was described to her on the phone. Harlan was standing near his office door. He wasn't quite inside, and he wasn't quite in the department. He was in the threshold, which struck Emily as appropriate in a way she didn't spend time on. She picked up a new pair of gloves from the dispenser at the station and snapped them on. She had patients in other bays. She still had a job to do, whatever the paperwork on the counter says about its status. She started toward the board to assess what had accumulated during the Marcus Webb crisis. "Nurse Shen." She stopped. It was Harlan's voice, from the threshold. She turned. He was looking at her with an expression she hadn't seen from him yet. Not defensive, not coldly institutional. Something stripped back from all of that. It wasn't comfortable to look at. She suspected it wasn't comfortable to wear. "The surgical resident," he said. "Martinez. She called surgery without my authorization." Emily waited. "You didn't ask her to do that," he said. It wasn't quite a question. No, she made that decision herself. "She's a good doctor," Emily said. "She reads of room." He absorbed that for a moment. "What she did was also a protocol violation," he said. Technically, Emily agreed. His jaw worked. "I haven't decided what to do with that yet. I understand." Emily held his gaze. "While you're deciding, the bed in Bay 7 needs attending." The patient came in about 20 minutes before all of this started. She's been waiting. She turned and walked toward Bay 7. Behind her, she heard Harlan move, not following her. Moving back into his office, the door closing with the particular controlled click of someone being very careful not to slam it. The next 2 hours had the specific texture of a difficult shift in the middle stages, not the raw crisis of the opening hours and not the exhausted decompression of the close, but the sustained midsection where the work is still heavy and the department's atmosphere carries the residue of what happened earlier, like humidity after a storm. People moved with the slightly elevated awareness that comes after a significant event. Conversations at the nursing station were quieter than normal, and more than one staff member found a reason to pass near the area where Emily was working. They weren't checking on her. Or they were, but they were doing it in the way that ER staff do most things obliquely, practically, without making anything of it. Ryan, the tech who had lent her the portable ultrasound, came by Bay 7 at 2:30 with a cup of coffee he set on the edge of the counter without comment, and then left. One of the other nurses, a woman named Polly, who had been in the ER for 9 years and had the no-nonsense effect of someone who had seen enough drama to develop a permanent immunity to it, stopped at the bay entrance during a chart review and said, without looking up from her tablet, for what it's worth. We all saw. From the beginning. Emily looked at her. Polly moved on without elaborating. General Marsh and his personnel had relocated to the family consultation room near the ER entrance. A small beige room with chairs that were designed to look comfortable without actually achieving it. Patricia Voss had joined them. Through the small window in the consultation room door, Emily could see the quality of the conversation. Heads forward, voices low, the occasional pause where someone took a note. Whatever was being discussed in that room was operating at a level above the department floor, and its outcomes would take longer to materialize than the next few hours. Emily knew that, too. She had learned patience from environments where patience was not a virtue so much as a survival strategy. At 2:58 a.m., Dr. Harlan came out of his office. He walked to the nursing station. He looked at the board. He made 2 clinical decisions about patients in bays 2 and 6 with the brisk efficiency of a man trying to reassert the rhythm of his authority by doing the work it was based on. He did not look toward where Emily was working. He did not speak to Donna except in clinical terms. Donna watched him the way she watched most things, with the complete attention she had learned to make invisible. At 3:20, the oar called down. Donna took the call. Emily watched her face from across the department. Donna's face stayed composed through the first 15 seconds of the call, and then something loosened in it. Not dramatically, just the release of a specific tension that had been present since midnight. She hung up. She looked across the department at Emily and gave one slow nod. Marcus Webb was out of surgery. Stable. The liver laceration had been repaired. The mesenteric tear was managed. Barring the unexpected, he would recover. Emily stood in the middle of the department for a moment and did nothing except let that information settle through her. Then she went back to work. The formal meeting happened at 4:15. Patricia Voss called it, not in the sense of scheduling it across a calendar, but in the sense of walking out of the consultation room and saying to Harlan and to Donna and to the charge supervisor, who had come in for the overnight, that they were going to sit down now. General Marsh accompanied her. His 2 uniformed personnel waited outside. Emily was included. The room was small enough that everyone was aware of everyone else's physical presence in a way that made social posturing harder than usual. Voss sat at the head of the table. Marsh sat to her left. Harlan sat across from Marsh, and his posture was the most controlled thing in the room. The rigid, deliberate composure of a man who had decided that whatever was about to happen, he was going to receive it as upright as possible. Emily sat at the far end. Donna had been asked to sit in as nursing representation. She sat beside Emily with a legal pad in front of her and wrote nothing on it. Voss began. I want to start by making clear that this conversation is not a formal disciplinary proceeding. Formal proceedings will follow their own process and their own timeline. This is a conversation to establish what happened tonight and what the immediate administrative response needs to be. She paused. Dr. Harlan, I'd like to hear your account. Harlan gave it. He was a precise speaker. He organized his account chronologically and clinically, presenting each he had made with the diagnostic reasoning that had supported it at the time. He did not minimize. He did not frame his choices as obviously correct in retrospect. He was too smart for that and too experienced with formal institutional processes to give anyone the material to accuse him of revisionism. He presented his actions as defensible based on available information, which was accurate. He acknowledged the protocol violation Emily had committed, the unauthorized ultrasound The IV placement, the failure to comply with the directive, to leave the patient. He did not raise his voice. He did not personalize any of it. It was, Emily recognized, a very good institutional defense. When he finished, Voss looked at Emily. Nurse Shen. Emily gave her account. It was shorter than Harlan's and more granular specific numbers, specific timestamps, specific observations. She described what she had seen in Marcus Webb's presentation from the first assessment. She described what the ultrasound had shown and when. She described the vital sign trend and at what intervals she had recorded it. She described the decisions she had made and the clinical reasoning behind each one. She did not describe them as correct. She described them as the decisions she had made and why she had made them, and left the evaluation to the room. When she finished, there was a brief silence. Then Marsh said, without preamble, "The patient is alive because of the decisions she made. 2 of those decisions violated protocols that were designed for normal operating conditions and not for situations where the physician of record met is declining to act on presented clinical evidence." He let that sit for a moment. "I'm not here to adjudicate hospital policy, but I want that context in whatever documentation comes out of this conversation." Harlan looked at him. The protocol violations created liability for this institution. The protocol violations kept that young man's circulatory system functioning until surgery could repair the source of the bleed. Marsh's voice was not raised. It didn't need to be. We can discuss liability frameworks. Or we can discuss what actually happened. I'd suggest the latter is more useful at 4 in the morning. Harlan was quiet. Voss made a note. This time her pen was moving. "The suspension action," she said, looking at the paperwork that had been placed on the tables at some point during the proceedings. "I'm pausing that effective right now, pending review. That's not a finding. It's an administrative hold while the situation is assessed properly." She looked at Emily. "You're not suspended. You're not cleared. You're in review, which means you continue your duties under standard oversight until we have a formal recommendation." Emily nodded. "Dr. Harlan." Voss turned. "I'm going to ask you to recuse from any cases involving Nurse Shen during the review period. Effective immediately." Harlan absorbed that for a moment. He stopped, recalibrated. "That's reasonable," he said. The words came out with the weight of something much larger being held in check behind them. The meeting concluded at 4:42 a.m. People filed out of the small room in the particular way that people file out of tense meetings. Not all at once, with small staggered gaps that provide everyone a moment to reset their face before re-entering a larger environment. Emily was the last one out. Marsh was waiting in the hallway just outside the door. "Walk with me for a minute," he said. They walked to the end of the corridor, where a large window looked out over the parking structure, and beyond it, the earliest beginning of gray at the eastern edge of the sky. Not dawn yet, not even close, but the first suggestion that the night wasn't permanent. Marsh looked at it for a moment. "You could have called me," he said, "when you took this job, when you transferred in. I didn't take this job to bring the army with me. I know that. I needed to do it on its own terms," she said. "Figure out if I could actually..." She stopped. Started again. Transition is not what people tell you it is. It's not a door you walk through. It's a long hallway where none of the lights work, and you have to find the wall with your hand. He was quiet for a moment. "How's the hallway?" "Getting wider," she said. He nodded. He didn't push it further than that. He was a person who had spent 30 years knowing when things had been said completely. "The review," he said. "Voss is going to try to run it cleanly. But Harlan has 20 years of institutional capital in this building. Allies on the board. People who owe him professional favors." He paused. "That capital doesn't evaporate because of one bad night. I know. I want to file a formal statement on your behalf. What I observed tonight, what your service record reflects. It goes into the review file. That's your call, sir." "It's a courtesy, Shen. I'm asking." She looked at the gray beginning at the horizon's edge. In a few hours, the day shift would arrive. The department would turn over. The nurses from the night shift would give their reports and go home, and the fluorescent lights would keep doing what fluorescent lights do. And Bay 4 would still have a slightly compromised monitor lead that needed recalibrating every 36 hours. Yeah. And none of what had happened tonight would be visible in the rooms itself. It would only be visible in the documentation, in the chart, in the timestamps that showed what was noticed when and what was done with that information, and by whom. Yes, she said, file it. At 5:10 a.m., Emily returned to the nursing station to check the board for the remainder of her shift. She had 4 hours left. The department had settled into the specific quieter rhythm of very early morning, the post-3a, where the black ice collisions had mostly resolved, and the next wave of the day's emergencies hadn't yet materialized. Donna was at the station, finishing her own documentation. She looked up when Emily sat down. "You should know," she said, "that Martinez, the resident." Harlan talked to her right after the meeting. Emily looked at her. "She's fine," Donna said quickly. It was strange. He wasn't punitive about it. He told her the surgery consult call she made was clinically sound and that she'd shown initiative. Donna paused. He also told her she'd violated the chain of command and that he expected her to come to him directly in the future. Emily processed that. "That's almost reasonable," she said. "I know. That's what surprised me." Donna leaned back in her chair. "He's not a stupid man. He's a complicated one. There's a difference." Emily didn't respond to that directly. She looked at the board. Bay 2 needed a follow-up assessment. Bay 6 had a new arrival. Bay 9 had a patient whose last charted vitals were 40 minutes old. She stood up. "Donna," she said, "thank you for staying through all of it." Donna looked at her with the slight exasperation of someone whose gestures of solidarity are being named out loud when they would prefer them to remain unspoken. "Don't thank me," she said. "I didn't do it for you. I did it because that kid on the gurney was 26 years old, and I have a son who is 24. She picked up her tablet. "Now go do Bay 9 before that patient's vitals get any older." Emily went. She was 3 steps from the nursing station when her phone buzzed. She looked at it. The number was from Ridgemont's administrative offices. Not a nurse line, not a clinical line. The administrative offices, which were currently empty at 10 in the morning, except for whoever had chosen to come in early or stay late, or been called in for a reason that didn't get explained in the text message that had just arrived alongside the call attempt. The text said, "Dr. Harlan's office, 600. You, me, and legal. Pivos." Emily stood in the hallway and looked at the message for a moment. Legal. At 6 in the morning, an hour and 10 minutes from now. She put the phone back in her pocket and continued toward Bay 9, because there was a patient there who needed her attention, and whatever was waiting in Patricia Voss's meeting at 6 a.m., it would wait for 55 more minutes without getting worse. She hoped. What she didn't know, what she had no way of knowing yet, was that the meeting Patricia Voss had called wasn't about the review process, wasn't about the suspension paperwork, and had nothing to do with the events of the night that had just ended. It was about something else entirely. Something that had been waiting in Ridgemont's institutional structure long before Emily Shen had ever set foot in Bay 4, something that Harlan's actions tonight had cracked open, the way a fault line cracked open, not because a single event caused it, but because the pressure had been building for years, and one significant shift was finally enough. And it was something that was going to make everything that had happened in the last 6 hours of a much larger story than Emily, look like getting large story than Emily had understood herself to be walking into. She made it to Bay 9 with 4 minutes to spare before the patient's next scheduled check. And she used those 4 minutes the way she used most available time, completely, without waste. The patient in Bay 9 was a 61-year-old woman named Harriet Odom, who had come in with chest tightness and had been triaged as a probable anxiety presentation by the overnight resident who had seen her first. Emily reviewed the chart looked at Harriet Odom's face, and within 90 seconds had a different working hypothesis. Harriet's pain was positional worse when she leaned back, better when she sat forward. And her history included a recent upper respiratory infection that Harriet had mentioned to the triage nurse, but that hadn't made it into the primary assessment notes with any emphasis. The EKG was on the board. Emily looked at it. The PR interval had a slight depression that the overnight resident had not flagged. She flagged it. She paged the cardiology fellow on call, documented her findings with the timestamps that had become as automatic as breathing over the past 6 hours, and stayed with Harriet until the fellow arrived. Harriet asked her in the way that patients ask when they're trying not to ask, whether she should be worried. Emily told her that they were being careful, which was true, and that careful was what you wanted people to be, which was also true. Harriet seemed to accept this and then asked if Emily had been on all night because she looked tired. Emily told her she was fine. She wasn't fine in the way that people are fine when things are easy. She was fine in the way that people are fine when they have learned to function through exhaustion, because the alternative stopping had consequences she was not willing to accept. Her feet hurt. Her lower back had a specific ache in the left paraspinal region that always appeared around hour 6 of a difficult shift. She had eaten nothing since the granola bar she'd had at 10:45 the previous night. She went to Bay 9 and then to Bay 2 and then to Bay 6, and she did her job with the consistency of someone who had decided at some point in her life that the doing of the job was not contingent on the conditions surrounding it. The department moved around her in the quiet of early morning, and the sky outside the high windows of the ER continued its slow, incremental shift from black to the particular deep blue that preceded dawn without yet committing to it. At 5:58 a.m., she went to the administrative wing. Patricia Voss's office was on the second floor, accessible from the ER by a stairwell that smelled like cleaning solution and old carpet and the specific institutional odor of a building that processed human suffering on its ground floor and paperwork above it. Emily climbed the stairs in her scrubs and her nursing clogs and her exhaustion, and she knocked on the office door at exactly 6A. Because arriving late to a meeting called by an administrator who had just paused, your suspension was not a choice she was going to make. Come in. The office was larger than it needed to be, and furnished in the language of institutional authority, dark wood desk, diplomas in matching frames, a credenza with folders arranged in a way that communicated organization without revealing content. Patricia Voss was behind the desk. Beside her, slightly behind and to the right, sat a man Emily hadn't met 50s, in a dark suit, with a leather portfolio on his knee and the particular watchful neutrality of an attorney at the beginning of the situation. He has been called in to assess. Harlan was not in the room. Emily sat in the chair across from Voss and said nothing, because the meeting had been called by Voss, and it was Voss's opening to make. Voss made it. "This is Robert Fenwick," she said, indicating the man in the suit. "He's hospital legal counsel. He's here in an advisory capacity." She folded her hands on the desk. "What I'm about to share with you is not public information. It's not part of your personnel review. It's contextual information that I'm sharing because I believe you need to have it, and because the events of last night in Planned have made it impossible to manage in the sequence I had originally planned." Emily looked at her. 3 weeks ago, Voss said, the hospital received a formal complaint from a former ER resident, Dr. James Pruitt. He completed his residency here 14 months ago and is currently in fellowship in Portland. She paused. The complaint concerns Dr. Harlan. Specifically, it alleges a pattern of retaliation against residents and nurses who questioned his clinical decisions. It names 6 individuals over a 4-year period. Pruitt was the 7th. The room was quiet. The complaint is under formal review by the hospital's compliance office. Voss continued. What happened last night with you was not supposed to intersect with that process. The timing is she stopped. It's not ideal. Emily processed this for a moment. How many of those 6 individuals left the department? She asked. Voss's expression confirmed it before she spoke. 4. The other 2 are still on staff. Neither of them knew about the complaint until 2 days ago. And now there's documentation from last night, Emily said. Time-stamped, photographed, witnessed by a general officer and a chief nursing officer and 20-odd staff members. Fenwick spoke for the first time. His voice was neutral in the way that trained legal voices are neutral. Not cold, but carefully non-committal. What happened last night is going to be very difficult to characterize as an isolated incident. Emily understood what he was telling her without him saying it directly. The events of last night had done to Harlan's institutional position what a single significant seismic event does to a structure that has been accumulating stress fractures for years. The fractures had been there. Last night had found them. What does this mean for my review? She asked. Voss and Fenwick exchanged a brief look. The suspension action is being formally rescinded, Voss said. Not paused, rescinded. Dr. Harlan does not currently have the standing to initiate disciplinary action against you, and the basis for the suspension does not hold up under the circumstances. She paused. You'll receive written confirmation within the hour. The protocol violations, Emily said, the IV placement, the unauthorized ultrasound, will be reviewed as part of the broader compliance process, Fenwick said. In that context, not in isolation. Emily nodded once. There's one more thing, Voss said. The one more thing took 12 minutes to explain and restructured Emily's understanding of the past 72 hours in ways she was still processing when she walked back down the stairwell at 622A. Among the 6 individuals named in Pruitt's formal complaint was a charge nurse named Sandra Moe, who had worked in the Ridgemont ER for 11 years before leaving abruptly 16 months ago. Sandra Moe had tried to escalate concerns about Harlan's pattern of ignoring nursing input on trauma cases through 3 separate internal channels over a 2-year period. All 3 escalations had been reviewed. All 3 had resulted in findings that characterized the concerns as professional disagreements, institutions within normal institutional parameters. And all 3 had been closed without action. 6 months after the 3rd closure, Sandra Moe had resigned. Her resignation letter, which Voss had reviewed as part of the compliance process and had apparently memorized in the relevant sections, used language that was careful and professional and said, between its careful and professional lines, that she was leaving because she had concluded that the system that was supposed to protect nurses who raised clinical concerns structurally incapable of doing so. And she was not willing to spend the remaining years of her career in a building that would not listen. What Voss had told Emily quietly, with Fenwick present as a witness to the disclosure, was that Sandra Moe had been contacted by the compliance office 2 weeks ago as part of Pruitt's complaint investigation. Sandra Moe had submitted a written statement. That statement was 63 pages long and documented, with the specificity of someone who had kept records in anticipation of exactly this moment. 11 separate clinical incidents over 2 years, in which Harlan had overridden nursing input in ways that she characterized as placing patients at measurable risk. 11 incidents. Over 2 years, documented, waiting in a file that the compliance process had now opened. Emily stood at the bottom of the stairwell and put her hand flat against the wall and let that settle through her. Not the vindication of it. She was too tired and too clear-eyed for the simple satisfaction of vindication, but the weight of it. 11 incidents. 11 patients who had moved through the department in the time that Sandra Moe had been watching and recording and trying to move the right levers. The years it had taken. The years Sandra Moe had spent after leaving, carrying that documentation, and waiting for a process that would actually use it. She pushed off the wall and went back to the ER floor. The day shift arrived at 7. The department's atmosphere shifted in the specific way it shifted during handoffs. The energy of people coming in fresh overlapping briefly with the particular depleted quality of the overnight staff producing a few minutes of heightened noise and movement before the outgoing shift thinned, the incoming shift, and the incomings settled into its rhythm. Emily gave her reports. She was thorough and precise in the way she was thorough and precise about everything. And the day nurses received the information without drama, because day nurses did not have the context for last night, and Emily was not going to provide it at 7 a.m. in the middle of a handoff. Harriet Odom, the 61-year-old from Bay 9, had been moved to the cardiac observation unit with a working diagnosis of pericarditis. The cardiology fellow had confirmed the PR depression pattern and the clinical picture. She would almost certainly be fine. Emily noted this in the handoff and moved on. She was in the locker room, changing out of her scrubs, when Donna came in. Donna sat down on the bench without ceremony and set her bag on the floor and looked at Emily with the expression of someone who has had a very long night and is about to have a very necessary conversation about it. "You heard about Mo," Donna said. Emily looked at her. "Sandra Mo." Donna's voice was even. "You heard. I can tell. Voss told me this morning." "I knew Sandra," Donna said. "I worked with her for 6 years." She was quiet for a moment. "When she left, I told myself the situation was complicated, that these things were always more complicated than they looked from the outside." She pressed her lips together. "I've been telling myself that for 16 months. Emily pulled her jacket on and said nothing. "I should have escalated when she was still here," Donna said. "I had my own concerns. I filed one internal note 2 years ago. It went nowhere, and I told myself I'd done what I could." She looked at her hands. "That's not actually what I could have done. Donna, I'm not looking for absolution. I'm telling you a true thing." She picked up her bag. Sandra kept records because nobody else was going to. And now those records are going to matter. She stood. "I want you to know that I'm going to submit my own statement to compliance about what I observed over the past 2 years and about last night." Emily looked at her. "You don't have to do that," Emily said. "I know I don't have to." Donna's voice had the slight roughness of a person saying something that costs something. "That's the point, isn't it?" She left. Emily sat on the bench for a moment in the quiet of the empty locker room. The fluorescent light above the mirror buzzed faintly, a single sustained note in the silence. She could hear the muffled sounds of the department through the wall, the day shift, finding its footing, the monitors doing their steady work, the ambient sound of a place that processed emergencies as a matter of operational routine. She had been awake for 23 hours. She went home. She slept for 6 hours and came back. Not because her shift had started. She had 48 hours before her next scheduled shift, and she was aware that rest was not optional, that the body did not negotiate with debt of this magnitude. She came back because General Marsh had left a message asking to meet before he and his personnel departed, and because there were things she needed to understand about what the next days were going to look like before she could navigate them with any accuracy. They met in the hospital's small outdoor garden, a narrow strip of plantings along the building's south wall, designed by someone who understood that people in hospitals sometimes needed to stand somewhere that was not inside a hospital. It was mid-morning by then, and the November air had the particular clean cold of high altitude at that time of year, sharp enough to make you conscious of breathing. Marsh was in civilian clothes. He looked different in them, smaller, somehow, or not smaller, but less armored. More like a person and less like a function. "I filed the statement this morning," he said. "Went to Voss and to the compliance office. Thank you." "Don't thank me. It's the accurate account of what I observed." He put his hands in his coat pockets. "The compliance investigation is going to expand. What started as Pruitt's complaint is going to pull in last night events and Mo's documentation and whatever else shakes loose. That's going to take months. I understand. During those months, you're going to be in this building, working alongside a man who has 20 years of institutional relationships and a very strong motivation to manage how this process develops." He looked at her directly. I need you to understand that careful documentation is not optional. I've been documenting everything since my first shift. I know. Keep doing it. He paused. There's something else. She waited. One of the individuals named in Mo's statement, he said. A patient case from 14 months ago. A trauma patient who came in after a construction accident, multiple rib fractures, pneumothorax. The nursing team flagged a tension pneumoprogression. Harlan delayed the needle decompression by Marsh stopped. Started again. The patient survived. But the delay caused complications that extended his ICU stay by 9 days and resulted in permanent reduced lung capacity on the left side. Emily was quiet. That patient filed a complaint with the state medical board 11 months ago, Marsh said. The board reviewed it and closed it without action, citing insufficient evidence that the delay was causally responsible for the outcome given the complexity of the presentation. He looked at her. Mo's documentation from that night includes a time-stamped note that was never submitted to the board review. Nobody knew it existed except Mo, and now it exists in the compliance file and will likely be forwarded to the board as new evidence. Marsh let that sit, which means the board complaint may be reopened. The cold air moved between them. Somewhere in the parking structure nearby, a car engine started and then moved away, and the sound dissolved into the ambient noise of the city. Emily understood what Marsh was telling her. The Pruitt complaint had opened a door. Mo's documentation had revealed what was behind it. Last night had provided the pressure that made the door impossible to close again. And now the process that had closed once without consequence was facing the possibility of reopening with evidence it hadn't previously had. The implications of that ran in several directions at once, and not all of them were straightforward. Harlan's lawyers are going to argue that Mo's documentation is retrospective advocacy, Emily said. That she kept selective records to build a case. Probably. And they'll argue that the board's original finding should stand because the new evidence is contextual rather than directly probative of causation. Marsh looked at her with something that might have been satisfaction if it weren't too complicated for that word. When did you learn medical board procedure? He asked. I've been reading since last night, she said. He almost smiled. The argument will be made. Whether it holds depends on what the rest of the compliance investigation finds and whether there are other cases in Mo's documentation with cleaner evidentiary chains. He paused. I understand there are. How many? 3 that legal considers strong. Possibly 4. Emily put that in the same place. She had put the information about Sandra Mo's 63-page statement that morning. Not compartmentalized exactly, but filed in a way that allowed her to function around its weight while she processed its full dimensions. I need to get back to work, she said. Marsh nodded. He understood operational priority. He had built a career on it. One last thing, he said. The resident, Martinez. Emily waited. She came to me this morning, on her own. Asked if she could submit an account of last night to the compliance process. He paused. She's a 3rd year. This kind of submission could complicate her relationship with the program director, who is one of Harlan's closest institutional allies. She knows that, I told her explicitly. And she asked me what the right thing to do was. Marsh looked at Emily. I told her that was a question she already knew the answer to, or she wouldn't have come to find me. Emily thought of Martinez, the young woman who had looked at the ultrasound screen at 12:51 in the morning and made a phone call she wasn't supposed to make, and then stood in the procedural and professional consequence of it with the kind of clarity that people either have or don't have, regardless of what their training tells them. She's going to be a good doctor, Emily said. Already is, Marsh said. She was back on the floor by noon. Not scared, she had asked Donna's replacement charge, a day shift nurse, some Terrence, whether the department was short. It was short by 1. She picked up 4 hours on the board and started in Bay 3 with a pediatric case. A 7-year-old with a suspected forearm fracture who was terrified of the X-ray machine and whose mother was on the verge of communicating that terror back to him, in the amplified form that parental anxiety takes in small enclosed rooms. Emily spent 11 minutes with the boy before the X-ray, talking to him about nothing related to hospitals. She asked him what his favorite dinosaur was. He said Ankylosaurus, with the specificity of a child who has thought about this seriously. She told him that the X-ray machine made a noise like a very boring robot, and that boring robots were much less scary than interesting ones. He considered this. He went to the X-ray. The fracture was a buccal fracture of the distal radius, common, straightforward orthopedic consult for splinting. She documented, coordinated the consult, made sure the mother had the follow-up information she needed. She moved to Bay 5. She moved to Bay 8. She was coming out of Bay 8 at 1:47 p. When she saw Harlan, he was at the far end of the department, coming from the direction of the administrative wing with a person she didn't recognize, a man in his 40s in a suit that was not the suit of a hospital administrator. It was the suit of someone from outside the building, which meant legal counsel or board representation, or something from the compliance structure. Harlan was talking in a low, continuous voice, and the man beside him was listening with the focused quality of someone being briefed. They passed through the ER without stopping. Emily watched them go. Terrence appeared at her elbow. "That's Wayland," he said quietly. "Harlan's personal attorney. He's been here since 10 this morning." Emily looked at the door that had closed behind them. "How long has compliance been in the building?" she asked. "Since 8. They've got the conference room on 3. 3 investigators, from what I heard. And they pulled a stack of charts. I don't know which ones." Emily thought about the chart from 14 months ago. The construction worker with the pneumothorax. The time-stamped notes that had never made it to the board review. If compliance had pulled charts, and if Mo's documentation cross-referenced specific chart numbers, then what was sitting in the conference room on the 3rd floor was a much larger body of evidence than a single bad night in November. It was a pattern, and patterns, once named and documented and placed in front of investigators with authority to act, had a completely different institutional weight than individual incidents. She was still thinking about this when her pager fired. Not her personal pager. The overhead trauma pager. The department-wide alert that brought everyone's head up simultaneously and compressed the ambient noise of the ER into a held breath. Mass casualty notification. Highway incident on I-80, Western Corridor. Multiple vehicles. Estimated 12 to 15 patients incoming. First unit's ETA, 11 minutes. The ER responded the way trained systems respond to sudden massive demand, not with panic, not with the cinematic chaos of people running in all directions, but with the organized urgency of a machine that has practiced for exactly this moment and knows its own moving parts. Terrence was already on the radio. The charge board was being restructured in real time. Beds were being cleared, equipment staged, the on-call surgical team paged, the blood bank notified. Emily moved to the trauma bay without being directed. This was her environment. This was the specific register of operational demand that her body knew how to meet with a clarity that bypassed the usual cognitive layers. Not instinct exactly, but something built from instinct and training and years of practice in conditions where hesitation had a cost that could be measured in the most direct possible terms. She was gloved and positioned and ready when the first ambulance pulled in at 2:01 p.m. The first patient was a 43-year-old male, unrestrained driver of a commercial van, blunt chest trauma, bilateral breath sounds diminished on the left, BP 90/58, heart rate 128. She begins her assessment before the finished speaking, and she had the patient's situation mapped in her head within 40 seconds. The second ambulance was 30 seconds behind the first. The third came while she was still managing the first patient. And then, in the middle of everything, in the controlled chaos of a mass casualty demise response with 12 incoming patients and a department running at full capacity, and every available clinician moving at speed, Victor Harlan walked into the trauma bay. He had come from the direction of administration. He was still in his street clothes. He had not been called in the mass casualty. Protocol had a separate call list for off-duty attendings, and Harlan was on administrative leave pending the compliance review, which meant he was not on that list and should not be here. He was here. He looked at the patient Emily was managing. He looked at the board. He looked at the controlled movement of the department, a department that was functioning without him, that was functioning without him, was functioning well without him, that had reorganized itself around his absence with the unsentimental efficiency of systems that are built to run rather than built to depend on any single person. He stood at the edge of the trauma bay. Emily glanced at him once. She went back to her patient. Breaths, sounds, she said to the resident beside her. Diminished left lower lobe. Trachea midline. Get me a 14 gauge. Left second intercostal midclavicular. The resident moved. Harlan watched. He was watching the way a person watches something they built that is running without them, and the expression on his face was not what Emily expected. Not anger, not territorial assertion. Something that had no clean word for it, complex and uncomfortable and entirely human in a way that his face hadn't been at 12:51 in the morning when he had ordered her out of Bay 4. She didn't have time to think about his face. She performed the needle decompression, heard the rush of air that confirmed tension pneumothorax successfully relieved, called for the chest tube setup, and moved to the next decision point in the clinical sequence without breaking rhythm. The patient's pressure came back up to 104/72 within 4 minutes. She moved to the next patient. When she looked up again, Harlan was gone. The trauma bay door was swinging closed, and Terrence was at her elbow, his face carrying the particular expression of someone who has just received information that have a clean category. Compliance called down from 3, he said. They need you upstairs. Now, Emily looked at her patient, the second patient, a woman in her 50s with probable pelvic fractures, currently being managed by 2 other nurses and the attending who had been called in on the mass casualty list. She's stable? For now. Get me 5 minutes. They said now, Emily. She looked at the board. She looked at the patients. She looked at the functioning, organized, capable department around her. The department that did not, in this moment, require her specifically to keep running. 2 minutes, she said. She finished the handoff to the attending on the pelvic fracture case, documented what she had done and what remained to be done, and then she pulled off her gloves and walked toward the stairwell. On the 3rd floor, the conference room door was closed. Through the small window in it, she could see 3 people around the table. 2 women and a man she didn't know, and a stack of manila folders and a laptop, and 1 additional person whose presence in that room stopped her hand on the door handle. Sandra Moe, sitting at the end of the table, in a plain gray sweater, with a posture that Emily recognized. The posture of someone who has been carrying something heavy for a very long time, and has finally, in this room, in this moment, set it down in front of people with the authority to do something with it. Sandra Moe looked up through the window. She looked at Emily, and on the table in front of her, spread across 4 open folders, were the records she'd kept for 2 years and carried for 16 months and submitted to a process that was finally, with whatever compound force the events of the last 12 hours had generated, in motion. Emily pushed the door open and went inside. She did not know yet, could not have known, that inside the 3rd folder, from Sandra Moe's left, beneath a chart from 16 months ago and a set of nursing notes that had never been filed, and a photograph of a monitor reading taken on a cell phone at 11:43 p.m. on a night that predated Emily's arrival at this hospital by more than a year, there was a name. Her name, written in Sandra Moe's handwriting on a note that had been added to the folder not 16 months ago but 3 weeks ago. When the compliance process had opened, and Sandra Mo had begun to understand that what was coming might need one more piece to hold together, the way it needed to hold together. Emily Shen, with a phone number, and 2 words beneath it. Find her. The 2 words sat on the page like something that had been waiting a long time to be read by the right person. Find her. Emily looked at them for 3 seconds. Then she looked at Sandra Mo, who was watching her from across the table with the particular quality of attention that belongs to people who have been managing a long and complicated plan and have just arrived at the moment where the plan either holds or it doesn't. Sandra Mo was 51 years old. She had the look of someone who had been through something protracted and had not come through it undamaged, but had come through it intact, which is a different thing entirely. Her hair was shorter than the photo on her old hospital ID that compliance had pulled for the file. Her hands were folded on the table, and they were steady. "You don't know me," Sandra said. "I know who you are," Emily said. "That's not the same thing." "No," Emily agreed. "It's not." One of the compliance investigators, a woman named Reyes Carver, no relation to Donna, who had introduced herself when Emily sat down with the brisk efficiency of someone who ran 12 of these processes a year and had learned to move them forward without letting them calcify into ceremony, spoke before either of them could continue. "Ms. Mo included your name in the file 3 weeks ago, based on information she received from a contact at the Army Medical Liaison Office," Reyes Carver said. She had been trying to identify a nurse with a specific clinical background who might be willing to work at Ridgemont under circumstances she anticipated would become relevant. Emily looked at Mo. "You set this up," Emily said. "Not an accusation, a recognition." "I set up a possibility," Mo said. "I didn't know if it would become necessary. I hoped it wouldn't." She unfolded her hands and placed them flat on the table. "But I've been through this process before. The internal complaint, the board review. I knew what happened to evidence when it sat in a file without a living, current witness to what it described." She paused. "I needed someone who was in that department right now. Someone who would see what I saw and document it the way I documented it and not back down when the pressure came." The room was quiet for a moment. "You didn't recruit me," Emily said slowly. "You just made sure the information about the position reached someone who might apply. The liaison contact knew I was looking for a specific profile: former military, trauma background, strong documentation habits." Mo's voice was even. "I didn't control whether you'd apply or whether you'd be hired or whether the situation would develop it needed to develop. I just opened a channel." Emily sat with this for a moment. The information had a specific weight and texture that took time to process properly. She had chosen Ridgemont because the position had matched her credentials, and the timing had worked, and the department had a solid trauma volume that she needed for her recertification hours. She had believed herself to be making an autonomous, professional decision. She had not been wrong about that, exactly. She had just been operating in a context that was larger than the one she knew she was in. "Why not come forward yourself?" Emily asked. "You had 63 pages. Without a current witness, 63 pages is an ex-employee with a grievance." Mo looked at her directly. "I learned that the first time. The board closed the complaint because the documentation was mine and I was gone, and Harlan's attorney made the argument that I had a personal motivation to overstate the pattern." She paused. "With you. With what happened last night, the documentation is current. It's witnessed. It's recorded in an active patient chart by someone who is still in the building. That's a completely different evidentiary weight." Reyes Carver cleared her throat. "We have a limited window this afternoon," she said. "I need Nurse Shen's formal statement about last night, and I need the clinical walkthrough of the web case in enough detail to support the broader pattern finding." She looked at Emily. "Are you able to do that now?" Emily looked at the closed door. 12 patients from a mass casualty event were being processed 3 floors below her. The department was running without her, but it was running full, and the mass casualty protocols, had a way of generating secondary complications in the 2 to 3 hour window after initial intake that required experienced eyes on the floor. "I need 90 minutes down there first," she said. "Then I'm yours for as long as you need." Reyes Carver looked at the clock on the wall. 2 p.m., she said. She gave the department 93 minutes. Because the secondary complications she had anticipated arrived at 1:48 in the form of a patient from the highway incident who had been initially triaged as stable and had spent 40 minutes in an observation bay before his oxygen. Saturation began a slow, quiet decline that the monitoring system caught, but that required interpretation before it triggered the appropriate response. Emily caught it on a pass through the board, connected it to his mechanism of injury, a lateral impact that had compressed his right chest and escalated to the attending on the mass casualty team. Pulmonary contusion, evolving. They had caught it in time. She documented it, handed off cleanly, and went back upstairs. The formal statement took 3 hours and 14 minutes. Reyes Carver ran it methodically, moving through the timeline of the Webb case in the specific sequence that compliance processes require. Not narrative, not emotional, but granular and time-stamped and cross-referenced against the chart at every decision point. Emily answered precisely. She did not editorialize. She described what she had observed, what she had done, what the documented response had been, and what the clinical outcome was at each stage. Sandra Moe sat through the first 2 hours and then was excused by Reyes Carver to wait in the adjacent room while Emily's statement was completed independently. Press it. When the formal statement was done, Reyes Carver set down her pen and looked at Emily with an expression that had moved slightly away from pure professional neutrality. "The Webb case alone doesn't establish the pattern," she said. "You know that, I know. But Webb combined with Moe's 11 documented incidents and Pruitt's account, and the 2 current staff statements gives us a body of evidence that the pattern finding requires." She paused. "The board case from 14 months ago, the construction worker, the tension pneumothorax delay, has 3 supporting items from Moe's file that were never submitted during the original review. We're forwarding those to the board this week. What happens then? The board reopens. Formally, with a scope that goes beyond the single incident to the broader pattern." Reyes Carver organized her folders with the movements of someone performing a practiced closing sequence. That process is separate from the hospital's internal findings. Both are moving now. Emily looked at the table for a moment, at the manila folders, at the 63 pages that Sandra Moe had carried for 16 months in the specific faith, not in any abstract sense, just in the practical sense of a person who believes that evidence, assembled carefully and presented at the right moment to the right process, eventually does something, that eventually there would be a moment for them. "What happens to Harlan?" Emily asked. Reyes Carver was quiet for a beat. "The hospital's internal process will produce a recommendation to the board of directors," she said. "The board will act on that recommendation. The nature of the action depends on the findings." She paused. "What I can tell you is that administrative leave pending investigation is the current status, and that the weight of what's in this room makes voluntary or involuntary separation from the chief of emergency medicine position extremely likely, and his medical license. That's the board's jurisdiction." Reyes Carver met her eyes. "The board does not close cases with this pattern of documentation without consequence. That's not how they operate when the evidence is disorganized." Emily nodded. She stood up. "One more thing," Reyes Carver said. Emily waited. "Dr. Harlan's attorney has already filed a motion with the hospital's legal office, arguing that your actions last night, the protocol violations, constitute grounds for independent disciplinary action against you, separate from and unaffected by the compliance investigation." She kept her voice even. "He's arguing that even if the investigation finds against Harlan, your violation should be adjudicated on their own terms." "He's not wrong that they were violations," Emily said. "He's not wrong about that. Reyes Carver folded her hands. But the hospital's legal counsel has reviewed the motion and has indicated that pursuing independent disciplinary action against you in the current context would be, she paused, selecting the word with care inadvisable. Because of how it would look. Because of how it would be, Reyes Carver said. And the precision of that correction was the closest she had come, in 3 hours, to saying something that lived outside the language of institutional process. Emily came back down to the ER floor at 5:40 p.m. The mass casualty patients had been distributed across the building ICU, surgical wards, observation units, operation units, and the department had returned to its normal volume with the specific depleted efficiency of a system that had run hard and was now managing its recovery. The board was full, but not overloaded. The staff on the floor had the look of people in the second half of a difficult shift, capable, focused, slightly quieter than they would be at the start. Donna was gone. She had left at end of her overnight, hours ago. Terrence was still there, running the charge board with the competent steadiness that had made him one of the most reliable charge nurses in the department's day rotation. He looked at Emily when she came in. "How'd it go?" he asked. "Long," she said. "You eat anything?" She hadn't. She took the protein bar he offered from his desk drawer without comment and ate it standing at the nursing station while she reviewed the board. She had been standing there for 4 minutes when the elevator opened. When the elevator opened and Marcus Webb's mother came out. Emily knew it was her immediately, the specific movement of a person navigating an unfamiliar institutional environment with the determined focus of someone who has a destination and will not be deflected from it. She was in her mid-50s, with Marcus's same coloring and the particular tightness around her eyes that comes from a night of sitting in a surgical waiting room. She stopped at the nursing station. "I'm looking for the nurse," she said. "From last night. The one who—" She stopped. Her voice had the slight roughness of someone who has been managing emotion for many hours in a room full of strangers and is now in a different room and doesn't need to manage it quite as hard. "The surgical team told me about what she found. What she did before they got him up there." Terrence looked at Emily. The woman looked at Emily. Emily put the remainder of the protein bar on the counter. "How is he?" she asked. "He woke up this morning." Marcus's mother pressed her lips together briefly. "He asked for water, and then he asked what happened to his car, and then he went back to sleep." She exhaled. "The surgeon said the access they had when he came into the OR, the IVs. He said it bought them the window they needed." Emily said nothing. "I wanted to find you," the woman said. "I didn't know how. They said there were some complications with staff last night. That the nurse who had been with him had—" She stopped again. She was trying to organize something that was difficult to organize. "I just wanted to say that I know what happened. My son told me, before surgery, when he was still lucid enough to— He told me about a nurse who kept coming back, who kept checking, who didn't stop even when someone told her to." The nursing station was quiet. Terrence had become very interested in his charge board. "He told me her name," the woman said. He remembered it. She looked at Emily. "You're Emily Shen?" "Yes," Emily said. The woman reached across the counter and put her hand briefly over Emily's. It lasted about 2 seconds. She didn't say anything else because there wasn't anything else that added to what had already been said, and she was, Emily recognized, someone who understood that. She turned and went back to the elevator. Emily stood at the nursing station for a moment after the elevator closed. Then she picked up the remainder of the protein bar and finished it and went back to work. At 7:15 p.m., Victor Harlan returned to the building, not to the ER. He came in through the administrative entrance on the building's east side. Emily only knew this because Terrence's phone received a text from someone in administration, and Terrence's face did the thing it did when information arrived that required rapid processing, and he showed her the text without being asked. "Harlan's in the building. Admin wing, 3rd floor. His attorney and 2 board members." Emily read it. She handed the phone back. What do you want to do? Terrence asked. My job, she said, and moved to Bay 3, where a patient had been waiting 12 minutes for a wound assessment. The next 40 minutes had the specific quality of the period before a decision arrives. Not the crisis itself, not the aftermath, but the narrow, suspended interval between them where everything continues as normal. Because the alternative is stopping, Maddox, and stopping is not a functional option in emergency department. She assessed the wound in Bay 3, coordinated an orthopedic consult for a patient in Bay 7, managed a pain protocol adjustment in Bay 1, and documented all of it in the precise time-stamped language that had become not just habit, but a kind of discipline, a practice she understood. Now was more important than she had originally framed it. At 7:58, Patricia Voss appeared at the ER entrance. She had changed clothes since the morning. She had gone home at some point and come back, which meant whatever was happening on the third floor had pulled her back in, which meant it was significant enough to require the CNO present in person after hours. She looked across the department until she found Emily. She walked over. I need 5 minutes, she said. They stood in the family consultation room, the same small beige room where Marsh and his personnel had been the previous night, which gave it, in Emily's perception, a slightly layered quality, as if the room itself had absorbed the residue of consequential conversations and held it in the walls. Voss closed the door. The board meeting is happening upstairs, she said. 2 board members, legal counsel, the compliance lead, and Dr. Harlan. She paused, and his attorney, who has spent the last 4 hours preparing what amounts to a counter-offensive. Emily waited. Harlan's attorney is arguing 4 things, Voss said, with the compressed efficiency of someone delivering a briefing. 1, that the compliance investigation was triggered by a biased complaint from a former disgruntled employee. 2, that the Webb case, while unfortunate in its outcome from a process standpoint, reflects a defensible clinical judgment call rather than a pattern of reckless disregard. 3, that your protocol violations last night were serious enough to constitute independent misconduct and should not be treated as mitigated by their outcome. And she paused slightly longer before the 4th. 4, that the Army General's presence last night constitutes improper external pressure on an internal hospital matter and that the compliance investigation has been compromised by that pressure. Emily processed the 4 arguments in sequence. The first 3 were predictable. She had anticipated versions of them from the moment Reyes Carver had described the motion filed by Harlan's attorney that afternoon. The 4th was not predictable. The 4th was not predictable. The 4th was a move she hadn't seen coming, and the fact that she hadn't seen it coming bothered her in the specific way that gaps in situational awareness always bothered her. He's arguing the whole process is tainted, she said. He's arguing it, strategically, Voss said. If he can get the board to accept that the investigation was initiated under conditions of external pressure and internal conflict of interest, it creates grounds to delay or restructure the process, which buys time, which gives his legal team room to work. Is it working? Voss looked at her steadily. One of the 2 board members in that room was appointed to the board 12 years ago, she said. On Harlan's recommendation, the room was quiet. What does the other board member think? Emily asked. The other board member, Voss said, has been reading Moe's documentation for the past 2 hours and has not said much, but what she has said has not been favorable to the argument that this is a biased complaint from a disgruntled former employee. Emily understood the shape of what was happening. A room divided by 2 different orientations, with Harlan's attorney working the seam between them, and the outcome not yet determined. Why are you telling me this? Emily asked. Because Harlan's attorney has requested that you be available for questioning. Voss kept her voice neutral. Not in a formal legal proceeding, the board meeting is internal. But he wants to put questions to you in front of the board. About last night. About your prior relationship with General Marsh. About whether the general's presence was coordinated in advance. Emily looked at her. It wasn't coordinated, she said. I know that. Marsh came because someone at the Army liaison office heard what was happening through the notification chain and passed it up. That's not coordination. That's an institution looking after one of its people. I know that too. Voss paused. Harlan's attorney is going to try to make it look like something else. He's going to ask you questions that are designed to make the relationship between you and Marsh look strategic, premeditated. She met Emily's eyes. I want you to be prepared for that. Emily thought about Sandra Moe's note. Find her, the channel that had been opened through the Army liaison contact. The way the position at Ridgemont had reached her through a sequence of connections that she had not known were connected. She thought about this for a moment, with the uncomfortable clarity of someone who is doing accurate accounting and not enjoying all the numbers. If he asks me directly about how I ended up at Ridgemont, she said slowly, and I tell the truth, and the truth includes the liaison connection to Moe. It changes the picture, Voss said. Yes, it doesn't change what happened last night. What Harlan did. The Webb case, Moe's documentation. No, it doesn't. Voss was careful, but it changes the narrative around your presence here. And narrative is what his attorney is working with right now, because the evidence is not working in his favor. Emily was quiet. The fluorescent light in the consultation room buzzed faintly. The sound of the ER came through the wall monitors. Movement, the ambient ongoing work of the department. Bay 4's light was probably flickering on its 12-minute cycle. Bay 4's patient was probably being seen by someone capable and careful who had no idea what that Bay had seen last night. He's going to ask me, Emily said. He's going to ask you, Voss confirmed. And if I answer truthfully, he uses the answer to argue that the whole thing was orchestrated. That Moe engineered a situation, planted a witness, and used a general's intervention to apply external pressure to a legitimate institutional structure. That's his argument, yes. And if I don't answer fully, you're under no legal obligation in an internal board meeting. Fenwick had said something like this that morning, she remembered. No legal obligation. But there were other kinds of obligation, and the people in this room understood that she knew the difference. Voss looked at her for a moment with an expression that was not quite sympathy and not quite solidarity, but lived in the territory between them. I can't tell you what to say, she said. I'm telling you what to expect. Emily stood up. What time does the board meeting reconvene? She asked. 8:30. She looked at the clock on the wall. 22 minutes. I need to make a phone call, she said. She made it in the stairwell because the stairwell had the specific acoustic quality of institutional concrete that absorbed sound rather than reflecting it. And because she needed 10 minutes of privacy, and the stairwell was the closest reliable version of that she had access to. Marsh picked up on the second ring. They're going to ask me about the liaison contact, she said. About how I got to Ridgemont. Harlan's attorney wants to argue it was orchestrated. A brief silence. Was it? Marsh asked. Not by me. No, he said. Not by you. If I tell the truth, he uses it. If I don't tell the truth, then you're not telling the truth. His voice was even. Which is not something I've known you to do, and I've known you in environments where the temptation to manage the truth was considerably more acute than a board meeting. She was quiet. Tell the truth, he said. The complete truth. Including Moe's note. Including the liaison channel. Including everything you know about how you ended up in that department. He paused. Because the truth does not undermine the case. The truth is that a former nurse kept records for 2 years and spent 6 months looking for a way to get them in front of a process that would use them. That's not a conspiracy. That's someone who cared enough to be patient. Another pause. And if Harlan's attorney wants to stand in front of a board of directors and argue that careful, documented, patient persistence is a form of fraud, he's welcome to make that argument. I'd like to see it. Emily looked at the concrete wall of the stairwell. You knew, she said, about Moe's note. The silence that followed lasted long enough to be its own kind of answer. The liaison contact who passed the information about the Ridgemont position, he said carefully, did so through appropriate channels. Nobody compelled you to apply. Nobody compelled Ridgemont to hire you. Nobody compelled Harlan to do what he did last night. His voice was steady. The truth is that a nurse who had been failed by every process available to her found a way to try one more time. The truth is that it worked because the people involved were competent and honest and didn't stop when it got hard. He paused. Tell that truth, she exhaled. 8:30, she said. I'll be there, he said. You're still in Salt Lake City? I've been in this city for 18 hours, waiting to find out if you needed backup. A pause that had something almost dry in it. Turns out you might. She looked at the clock on the stairwell wall. 18 minutes. She put the phone in her pocket. She stood in the concrete stairwell, and she thought about Sandra Moe sitting alone in an adjacent room on the 3rd floor. 63 pages on the table, 16 months of patience behind her, waiting to find out whether the thing she had built so carefully was going to hold, or whether the man who had dismantled it once before was going to find the right lever and do it again. She thought about Marcus Webb waking up that morning and asking for water and asking about his car. She thought about the construction worker from 14 months ago, a man she had never met whose name she did not know, who had lost permanent lung function on his left side on a night when the right call had been available and had not been made. And she thought about the 11 other cases in Moe's folders, each one a patient who had moved through this building and been failed not by medicine, but by the specific failure of a system that had protected one man's authority at the cost of clinical truth. She thought about Bay 4. The flickering light, the blue tape. Pull hard, curse freely. She thought about what Sandra Moe had written on a piece of paper 3 weeks ago and placed in a folder and waited for the right moment. Find her. Emily straightened. She opened the stairwell door. She went upstairs, and she was 3 steps from the conference room when the door opened from the inside and Harlan's attorney, the man in the suit she had seen earlier, who had the polished, unhurried quality of someone who had won enough of these to believe. Winning was his default, stepped into the hallway with a document in his hand and looked at her with the specific expression of a man who has just been handed by someone inside the room a piece of information that has changed the shape of his strategy. He looked at the document. He looked at Emily. Nurse Shen, he said, there's something you need to see. He held out the document. She took it. It was a transfer request, dated 6 weeks ago, submitted to the Ridgemont Administrative Office through the hospital's standard inter-facility transfer system. The requesting physician was listed in the standard field. The requesting physician was Victor Harlan. The requested transfer was not of a patient. It was a staff transfer request, a formal request to block the hire of a specific nursing candidate whose application was then pending review. The candidate's name in the transfer request was Emily Shen. Harlan had known she was applying. He had tried to block her hire. The request had been processed by an administrative coordinator who had filed it incorrectly in the outgoing transfer queue rather than the incoming hire review queue, and it had sat in the wrong folder for 6 weeks without being actioned, and Emily had been hired in the interim by a hiring committee that had never seen the request because it had been misfiled before it reached them. Harlan had tried to keep her out of the building. She had gotten in anyway. And everything that had followed, the Webb case, Moe's documentation, the compliance investigation, the board meeting happening right now on the other side of that door had, followed from the administrative error that had let her through a door that had been quietly, deliberately closed against her before she ever arrived. Emily held the document. She looked at Harlan's attorney. His expression had shifted from the controlled confidence of someone deploying a strategic reveal to something considerably more complicated, the expression of a man who has just realized that the document he was handed as a weapon has a second edge he did not examine before he handed it over. Because the document did not show orchestration. The document showed that Victor Harlan had known Emily Shen was coming and had been afraid of it. And the question that document raised, the question that was going to be in that conference room in approximately 90 seconds, was not why Emily Shen had ended up at Ridgemont Trauma Center. It was why Victor Harlan had tried to make sure she didn't. The attorney's hand was still extended in the space between them, suspended in the specific stillness of a man who has just watched his strategy invert itself in real time. Emily read the document a second time, not because she had missed anything the first time, because she needed the second reading to confirm that the document said exactly what it said, that she was not assembling meaning out of exhaustion and the accumulated pressure of the past 36 hours. It said exactly what she thought it said. Victor Harlan had submitted a formal request to block her hire 6 weeks ago. He had known her name before she walked through the door. He had seen her application, her credentials, her military background, her 3-year gap listed as federal service non-clinical, and something in that file had alarmed him enough to try to close the door before she reached it. The question was not complicated once you held the document in your hand and let it mean what it meant. He had been afraid of what she represented before he had ever met her, not of her specifically. Of the category, she belonged to people who documented carefully, who didn't stop when told to stop, who didn't stop when told to stop, who came from environments where the cost of ignoring clinical truth was measured in rather than institutional inconvenience. He had seen enough of that profile over 20 years to know what it did to systems like the one he had built. And he had tried, quietly and through proper bureaucratic channels, to keep that profile out of his department. The administrative error that had misfiled his request had not been large. A coordinator entering a code incorrectly. A document landing in the wrong queue. The kind of small operational failure that happens in every large institution every day. The accumulation of minor human imperfection that most of the time produces nothing consequential, and this time had produced. Everything that had followed from Emily's first shift in Bay 4. Everything that was now sitting in 4 manila folders on a table 1 room away. She lowered the document. She looked at the attorney. He had recovered his composure in the interval. He was too practiced to let it stay gone for long, but the recovery was visible if you knew what to look for. The slight overcorrection in his posture, the way his hands had moved from relaxed to deliberately still. "Who gave you this?" she asked. "It was in the compliance file," he said. "Pulled with the administrative records this afternoon. And you were planning to use it as what exactly?" He chose his words with the care of someone who has just realized the footing is uncertain. "As context," he said, "for the board's understanding of how this situation developed." Emily looked at him for a moment. "That document shows that, Doctor. Harlan identified my application and tried to prevent my hire," she said. "What context does that provide that helps your client?" He had no answer to that, not a usable one. She could see him working through the architecture of the argument he had been building and finding that this particular stone, placed where he had intended to place it, did not fit the structure anymore. She walked past him and opened the conference room door. The room held 6 people around a rectangular table. Reyes Carver from Compliance, Robert Fenwick representing Hospital Legal, 2 board members, a man in his 60s named Aldridge, who had the settled authority of someone who had occupied institutional power long enough to be shaped by it, and a woman in her 50s named Dr. Priya Nair, who had the specific alertness of someone who has been reading for 2 hours and has found the reading disturbing, and Victor Harlan, who was seated at the far end of the table with the contained posture. Emily had catalogued over the preceding night and day the posture of a man who had decided that whatever came at him, he would receive upright. Sandra Moe was not in the room. She was still in the adjacent space, waiting. General Marsh was not in the room. He was somewhere in the building. He had said he would be there, but he was not here yet. Emily placed the transfer request document on the table in front of board member Aldridge. "This was in the compliance file," she said. "I was just shown it in the hallway." Aldridge looked at it. His expression moved in a direction Emily couldn't fully read. Nair leaned forward, read it from across the table, and sat back. The room was quiet for a moment. Then Harlan spoke. "I submitted that request," he said. His voice was level. "I won't pretend otherwise." Aldridge looked up from the document. "Victor, why?" The word sat in the room without embellishment. Not a formal question, not a procedural prompt. The voice of a man who had known another man for a long time and was asking something that was partly institutional and partly personal and entirely serious. Harlan was quiet for a moment. "Her file had the military background," he said. "The trauma certification. The gap in employment that read as field service." He paused. "I've hired nurses like that before. They come in and they're good. They're often very good, and they have a way of operating that doesn't account for the realities of how a civilian department runs. They push against protocols. They don't accept established hierarchies." He paused again. "I thought it would create friction." "You thought I'd be a problem," Emily said. He looked at her directly. "Yes," he said. It was the most honest thing he had said in her presence. "And you were right," Emily said. "I was." He absorbed that. "But the friction wasn't the problem," she continued. "The problem was what the friction found." She kept her voice even and clinical and entirely without performance. "If the department had been running cleanly, I would have created friction and either adapted or left. The friction found something, because there was something to find." The room was quiet. Nair spoke. Dr. Harlan, the document in front of Mr. Aldridge, combined with the compliance file, combined with Moe's documentation, and Pruitt's account, and the 2 current staff statements. She paused. "What is your response to the pattern finding?" Harlan looked at his hands on the table for a moment. His attorney, who had followed Emily into the room and taken a position near the wall, made a small movement, a slight lean forward, a preparatory shift, the beginning of an intervention. Harlan raised one hand slightly. The attorney stopped. "I need to speak without counsel for a moment," Harlan said. The attorney's lean reversed itself. Harlan looked at the table. Then he looked at Nair. Then finally, he looked at Emily. "The pattern finding is accurate," he said. The room did not explode. It did the opposite. It's compressed. The way rooms compressed when something that has been held under pressure for a long time is finally released, and the air has to recalibrate. Aldridge set the document down, Harlan continued. "It's accurate in the sense that I consistently prioritized my own clinical judgment over nursing input in ways that were not always warranted by the evidence." He spoke slowly, not as performance, but as someone doing the actual work of saying true things about himself that he has not previously said out loud. "I believed that I had more relevant experience than the nursing staff in most situations. I was right about that in aggregate and wrong about it in the specific cases where it mattered most." He paused. The web case. The construction worker 14 months ago. Moe's documented incidents. I made decisions that placed institutional hierarchy above clinical accuracy, and patients were harmed by some of those decisions. The attorney near the wall had gone very still. "I also," Harlan said, "attempted to prevent the harm of a nurse whose profile I found threatening to my operational authority. That was not a clinical decision. That was a self-protective one." He looked at Emily, and it was wrong. Emily said nothing. She had waited a long time in her professional life for a version of this moment, not from Harlan specifically, but from the structure he represented. The long institutional hallway where the lights didn't work, and you found the wall with your hand. She had not expected the moment when it came, to feel like this, not triumphant, not vindicated in the uncomplicated way that vindication looks in simpler stories. Just real. Heavy and real, and marked by the specific texture of things that have cost something to reach. The board meeting concluded at 10:14 p.m. The formal findings would take weeks to document and process through the appropriate channels. but the shape of what had been decided was visible in the room before anyone left it. Harlan would resign as chief of emergency medicine. Not terminated. The distinction mattered legally, and he had earned it by the honesty of the past 20 minutes, which Nair had noted explicitly and Aldridge had not contradicted. He would resign, effective at the end of the administrative review period, and the resignation would be accompanied by a formal acknowledgement of the compliance findings that would become part of the permanent institutional record. His medical license review would proceed through the state board as a separate process, with Mo's full documentation and the new items submitted to the board that week. That process would not be controlled by Ridgemont, would not be managed by his attorney in a small conference room, and would move at the board's pace regardless of what anyone in this building preferred. The 3 cases from Mo's file with the strongest evidentiary chains, including the construction worker from 14 months ago, would be formally reviewed for patient notification and potential remediation. The hospital's legal exposure from those cases was significant and would be managed by Fenwick's team over the following months. Emily's protocol violations from the Webb case would be reviewed and formally closed as justified under emergency clinical discretion provisions, with a notation that the outcome supported the clinical necessity of the actions taken. She was cleared, not celebrated. Cleared, which was the accurate word for what an institution does when it acknowledges, in the specific language of formal process, that a person acted correctly in circumstances where the structures around them had failed. She walked out of the conference room at 10:17 p.m. and stood in the hallway. Sandra Mo came out of the adjacent room. They stood in the hallway together for a moment. The institutional corridor was empty except for them. The cleaning staff had been through earlier and left the floor with the specific scrubbed quiet of institutional spaces after hours. Fluorescent lights running at full brightness over nothing in particular. It held, Sandra said. It held, Emily said. Sandra looked at the closed conference room door. Something moved through her face. Not relief exactly, because relief implies that the danger is past, and she understood better than anyone that the processes now in motion would run for months and produce outcomes she couldn't fully predict. But something that was the emotional equivalent of setting down a weight that had been carried for a very long time and letting your arms hang at your sides and feeling what that was like. 16 months, Emily said. 16 months and 4 days, Sandra said. I counted. Emily looked at her. At the plain gray sweater and the steady hands and the 63 pages that had waited in a file for the right moment, assembled by a woman who had been failed by every available process and had chosen, instead of leaving quietly, to stay in the fight from the outside with the only tools she had left. You should have been protected the first time, Emily said. Yes, Sandra said simply. I should have. There was no apology Emily could make for the institution that had failed her. There was no language that covered the 16 months, or the career interrupted, or the weight of being the person in the room who was right and could not make anyone hear it. Emily knew this. She didn't try to fill the space with words that wouldn't fit. What happens now? She asked instead, for you. Sandra was quiet for a moment. I offered my position back, she said. Voss called me this afternoon. She paused. I haven't decided. That's fair. I don't know if I can work in that department again, Sandra said. I want to. I think I want to. But wanting something and being able to do it are different things, and I'm being honest with myself about that. She looked at Emily. Is that terrible? No, Emily said. It's accurate. Sandra made a sound that was almost a laugh. You sound like you've had practice with honesty. Specific kind of environments, Emily said. It becomes a habit. Sandra nodded. She picked up her bag from the chair just inside the adjacent room. She looked at Emily one more time with the expression of someone completing a transaction that has taken a very long time and a great deal of cost, and is now finally finished. Thank you, she said, for not backing down. Emily watched her walk to the elevator. She stood in the hallway alone for a moment. Then she took the stairs back down to the ER. Marsh was in the parking lot. He was leaning against the side of a dark SUV with his hands in the pockets of his civilian coat, and the particular patience of someone who has learned to wait in difficult conditions and has found that parking lots in November are considerably less difficult than most. He looked up when Emily came through the exterior door. "It's done," she said. "I heard." He paused. "How are you?" She thought about this. Honestly. "Tired," she said. And something else. "I don't have a word for it yet." "You will," he said. "Give it a few days." She stood in the cold air and let it work on her the way cold air works when you've been in institutional interiors for too many consecutive hours, cutting and clarifying, using everything to its actual temperature. "He tried to block my hire," she said. "I know. And you knew he might. That's why Mo wanted someone with my profile specifically. Because a military-trained trauma nurse with strong documentation habits was the kind of person that someone like Harlan would react to." Marsh was quiet. "The liaison contact," Emily said. "They didn't just pass along the job posting. They were looking for a reason to pass it along. They were looking for the right posting to match to the right person." "You applied of your own choice," Marsh said. "You were hired on your credentials." "That's not what I asked." He looked at her. "No," he said. "It isn't." The parking lot was quiet. A car moved through the far entrance and found a space near the building, and a person got out and walked quickly through the cold toward the hospital's main entrance. The ordinary movement of a place that processes emergencies continuously, without pause, regardless of what happens in its conference rooms after hours. "You could have told me," she said. "You wouldn't have gone in the same way," he said. "You would have been managing it from the beginning. Second-guessing every decision against the context of knowing why you were there. Maybe I would have been more effective." "Maybe," he said. "Maybe not. What happened in that department happened because you were doing your job without an agenda. Because you saw a patient who needed something, and you fought for it without reference to anything except the clinical picture in front of you." He paused. "That's why it worked." Emily looked at the hospital building. The lights in the CR wing burned steadily at the ground, white and unwavering, the specific brightness of a place that does not get to turn off. "I'm not angry," she said, testing the statement as she said it. "No, I don't know what I am." She looked at the building. The patient survived. The documentation is in front of the right people. The process is running. She paused. "That's what it was supposed to accomplish." "Yes," Marsh said. "I just would have liked to know," she said. "That's all." He nodded. He didn't defend it further. He was a person who understood the difference between explaining and justifying, and he had explained. They stood in the parking lot for another minute, not because there was more to say, but because some moments require a little time before they can be classified and filed and moved past. "What are you going to do?" he asked. "Go home," she said. "Sleep." She paused. "Come back tomorrow. And after that?" She thought about Bay 4. The monitor that needed recalibrating every 36 hours. The supply cart and its new drawer handle. The 12-minute flicker in the overhead light that she had reported on her first shift and that maintenance had finally replaced. 2 days later, so that the bay was now lit consistently and evenly in a way it apparently hadn't been for several months before she arrived. Small things, functional things, the kind of things that didn't register as significant until you understood that every small functional thing in a trauma bay was a component of the system that either worked or didn't when it mattered. "I want to change the escalation protocol," she said. The process for nurses to raise urgent clinical concerns when the attending isn't acting on them. Right now it takes too long and has too many points where it can be blocked by the physician of record. She paused. "I want a direct escalation path. Nursing to charge to senior attending, bypassing the physician who's the subject of the concern. With documentation requirements that trigger automatically." Marsh looked at her. "That's a policy change," he said. "That requires board approval." I know. She looked at him. I'll be at the next board meeting. Something moved through his expression. Not quite a smile, because it was too complicated for that, but something in the vicinity. You'll want that in writing before you go in, he said. I know how to document things, she said. He pushed off the SUV. Get some sleep, Shen, he said. He got in the vehicle and drove out of the parking lot, and the taillights disappeared around the corner of the parking structure, and Emily stood in the cold for another moment by herself. She went home. She slept 8 hours. Not well, not in the smooth, uninterrupted way that sleep is supposed to work, but in the fragmented and occasionally turbulent way that sleep works after the body has been through something significant and needs to process it before it can rest. She woke. It's 6:43 a.m. with the specific someone who has come through to the other side of something and can now see the full shape of it from a different position. She made coffee. She sat at her kitchen table in the particular quiet of a morning that had not yet become a day, and she thought about Marcus Webb asking for water and asking about his car. She thought about the construction worker she had never met. She thought about Sandra Mo's hands on the conference table, steady, and the 63 pages, and 16 months, and 4 days. She thought about Bay 4 before she arrived. The flickering light, the broken drawmonitor leads, the compromised monitor leads, and she thought about how long it had been like that before someone decided it was worth fixing. Not because it was unfixable, because it had become normal, because the people working in it had adjusted to the dysfunction and stopped registering it as something that could be different. That was the part that stayed with her, not Harlan. Harlan was a specific person with a specific history and a specific set of choices, and those choices were now being processed by the systems that existed to process them. He would face consequences that were real and proportionate and that she had not manufactured. She had only documented what was already true. That was all she had ever done. The part that stayed with her was the light. The 12-minute flicker that everyone had adjusted to. The drawer handle replaced by tape because nobody had gotten around to fixing it. The monitor leads that ran slightly slow and gave slightly unreliable readings that everyone had learned to mentally correct for. The 1,000 small compromises that accumulate in systems that lack people willing to say, this is not acceptable, and I can fix it, and I am going to fix it now. She had been in environments where those compromises cost lives directly, where the stakes of ignoring the flickering light were measured in the most absolute possible terms. She had carried that knowledge into a civilian emergency department, and she had applied it, and people who had the authority to stop her had tried to stop her, and she had not stopped. That was the thing she had done. Not heroic. She was honest enough not to use that word for it. Just, she had not stopped. She finished her coffee. She went back to work. 3 weeks later, the state medical board formally reopened the complaint against Victor Harlan. The notification arrived in the hospital's administrative office on a Tuesday morning. By Tuesday afternoon, it had moved through the institutional channels that such notifications move through, and by Tuesday evening, most of the clinical staff at Ridgemont knew that the board was taking the case seriously in a way that the original review had not. Harlan had been on administrative leave since the night of the board meeting. His office had been cleaned out by a colleague under the direction of administration. Personal items boxed and held for collection. His name had been removed from the department's attending schedule. The residency program director, who was Harlan's institutional ally and had been named in Pruitt's complaint as having been aware of the retaliation pattern, was also under review. The position of Chief of Emergency Medicine at Ridgemont Trauma Center was posted internally, pressed 2 weeks after the board meeting. Emily did not apply for it. She was asked by Patricia Voss directly whether she had considered it. She said she had and had decided against it. She was a nurse. She wanted to remain a nurse. The things she wanted to change in the department did not require her to stop being a nurse. They required her to stay on the floor, doing the work, and use the standing she had earned to advocate for the changes in the rooms where those decisions were made. Voss listened to this. The escalation protocol proposal, she said. I want it on the board agenda for next month. I want it from you, in writing, with clinical justification. You'll have it by end of week, Emily said. The protocol proposal took her 4 days to write, not because the content was complicated, but because she wanted it to be precise, because precision was the only version of anything she knew how to do, because she had learned in conditions where imprecision had a cost that she was never willing to pay again. She submitted it on a Friday afternoon. Reyes Carver, from compliance, who had stayed involved with Ridgemont's process beyond her initial investigation mandate, read it over the weekend and sent back 2 notes, one suggesting a modification to the documentation trigger language, and one that simply said, "This is good work." The board approved it at the next meeting. It became policy effective the 1st of December. The escalation protocol, formally titled the Clinical Concern Escalation Standard, which was the kind of institutional language that made the thing sound bureaucratic when what it actually was a door that had previously been locked and was now open applied to every nurse in every department at Ridgemont. It meant that when a nurse raised a clinical concern and the attending physician failed to act on it, there was a clear, documented, protected path to escalate that concern to a senior physician without fear of retaliation. It meant that the escalation itself was logged automatically, creating a record that could not be retroactively removed or recharacterized. It meant that the next Sandra Moe, whoever she was, whatever department she worked in, whatever attending she was trying to move had a process that would hear her before she had to leave the building. It was not a perfect system. Emily had not designed it to be perfect because she did not believe in perfect systems. He believed in systems that were better than the ones they replaced and that had built-in mechanisms to identify and address their own failures. The protocol had review provisions at 6 and 12 months. It had a modification process. It would be imperfect in ways she couldn't predict, and she would deal with those imperfections when they materialized. That was the work. On a Thursday afternoon in December, Marcus Webb came back to the hospital, not as a patient. He walked in through the main entrance in street clothes, 6 weeks post-surgery, with the slightly careful movement of someone whose body is still negotiating its recovery, but is mostly back to functional. He found the ER nursing station by asking at the information desk, and he found Emily at the nursing station by the same method he had apparently been using since he regained enough coherence to think about it. She was at the board when she heard someone say her name from behind the station, and she turned around and he was standing there, looking somewhat better and somewhat younger than the last time she had seen him, which had been on a gurney with a blood pressure, reading that she preferred not to think about. "I wanted to come in person," he said. "My mom came a while ago, I know. But I wanted to—" He stopped. He had the expression of someone who has rehearsed something and is now discovering that the rehearsed version doesn't fit the actual room. "I wanted to say it myself." Emily looked at him. "You're recovering well?" she said. It was clinical and genuine, and both of those things at once. "The surgeon says another month, and I'm back to normal. Mostly." He paused. "The left side is going to be a little. They said there might be some residual." He stopped again. "That's not." He took a breath and abandoned the medical framing entirely. "I know what you did. I know what it cost you to do it. I know you got ordered out of that room, and you found a way to do it anyway." Emily said nothing. "I'm not good at this," he said. "You're doing fine," she said. He looked at her with the direct, slightly unpolished quality of someone saying something true, without the benefit of knowing how to make it sound better than it is. "I'm 26. I have a lot of time left, and the reason I have it is because you wouldn't stop." He paused. "I don't know how to say that in a way that's big enough." "You don't have to make it big," Emily said. "You just have to go live it." He looked at her for a moment. He nodded. He turned and walked back out through the entrance into the December afternoon, into the rest of the life he had almost not had. Emily stood at the nursing station and watched him go. Donna appeared beside her. She had developed, over the weeks since November, the specific habit of materializing in Emily's peripheral vision at moments of significance, as if she had calibrated herself to the frequency. "He looks good," Donna said. "He does," Emily said. They stood together at the nursing station for a moment, looking at the entrance door that had swung closed as points. "The protocol goes live next week," Donna said. "Monday. I've already had 2 nurses ask me about it." Donna paused. "Good questions. Specific ones. About their actual cases." She paused again. "That's the thing about opening a door. People were already standing behind it." Emily looked at the board. 3 patients waiting. 2 in active treatment, the work ongoing as it always was, as it always would be. "Bay 4's monitor is running slow again," Donna said. "I'll recalibrate it before the next shift," Emily said. She pulled on a fresh pair of gloves. She went to Bay 4. The overhead light was steady fixed, weeks ago, and holding. The supply cart had its handle. The monitor leads needed recalibrating, which she did in 4 minutes, with the focused efficiency of someone who had done it enough times to understand exactly where the drift originated and how to correct it without the workaround that everyone before her had accepted as the permanent condition of the thing. She checked the calibration. Accurate. She looked at the bay, at the functional, ordinary, unglamorous workspace that had been the beginning of all of it. The patient who had come through the door and the warnings that hadn't been heard, and the orders that had been given, and the room that she had been removed from and returned to, in the end on her own terms. There was no clean lesson in it. Real things don't produce clean lessons. They produce complicated ones, partial ones, ones that require ongoing revision as new information arrives. What she knew was this: the system that had failed Sandra Moe and the construction worker and the 6 people named in Pruitt's complaint had not failed because it was uniquely corrupt or uniquely broken. It had failed because it had never been forced to account for itself. And it had been forced, finally, not by a hero or a crusade or a dramatic singular act, but by a nurse who had walked into Bay 4 on a Tuesday morning and fixed the drawer handle and recalibrated the monitor leads, and then, when a patient arrived who needed someone to keep paying attention, had paid attention without stopping. That was the whole of it. That was enough. She stepped out of Bay 4. She went to work. And the emergency department moved around her with the continuous, unsentimental, necessary rhythm of a place that did not stop for anyone, that processed its crises and its recoveries, and its small daily victories, and its failures and its beginning agains, with the same unwavering operational pulse. Shift after shift, year after year, the rhythm of a system that worked better than it had last month, and would be asked to work better still next month by the inside it, who had decided that better was not a destination, but a direction, and that the direction was worth holding even when the hallway was dark and the walls were the only thing you had to find your way by.